Hello, dear colleagues, students, and audiences from all around the world. Thank you for joining us, and it is our honor to be with you on this program, Digital Prosthetic Dentistry. As you know, we have the same presentation last year, but still we think that it is better to do it again because digital prosthetic dentistry and digital technologies in dentistry are very new, and every day they develop, they grow and progress. So whatever we talked about last year, there are new technologies introduced to the market and to the dentists. So again, we are talking about it. Prosthetic dentistry is about replacing of lost tooth structure and adjacent tissues with the ultimate goal of restore the oral health, provide the patient with a prosthesis that is durable, functional, aesthetically acceptable, regardless of the kind of technology that you are using, whether it is conventional or new technologies. And our goal is, as a dental healthcare provider, to give the patient that provides him or her and the best benefits. The treatment duration, the treatment time to be as minimal as possible, less detrimental to the health of the patient. It could be in conventional techniques or in new technologies. It depends on which one is more beneficial to the patient. And we should know, that's why we should know. We should get familiar with new technologies to use them whenever it helps the patient to receive a better treatment. And the step of treatment in fixed restoration is diagnosis and treatment planning, tooth preparation, impression technique, manufacturing of the restoration, and cementation. This is common between two conventional and new technologies. However, there are small differences. Dr. Ghazanfari, the next presenter after me, is talking about the digital and conventional workflows. So you will see the differences between these two technologies and two techniques, actually. In 1973, Dr. Duret the first scanning of the teeth, and in 1989, Dr. Duret made a Cadcam system. However, in 1987, Dr. Morman and his colleague and electronic engineer, Dr. Brandestini, made the CEREC, the first commercial Cadcam system. In 1994, the second generation of CEREC was launched, and in 2000, third generation of the CEREC system and CEREC in lab were launched. After then, there are a lot of systems that have actually somehow Cadcam technology in them. Here, the preparation of the tooth, after preparation of the tooth, we have, instead of taking intraoral impressions, but by impression materials, we use oral scanners. And then instead of working in lab by last wax technique or something like that, and the software designs the restoration, and it orders the milling machine to do the restoration, to make the restoration. Dr. Nopar in 2 hours, in about 2 hours, show you how a crown is going to be made by a Cadcam system. The point is the system that scans the teeth. It means the scanner, whether it is intraoral scanner or lab scanner, should be compatible with the software. It means that the software should read the data that is collected by a scanner. If it doesn't, they are incompatible. They can't use with each other. Also, the milling machine should read the orders that is given by the software. So all these 3 parts, 3 components of Cadcam system should be compatible with each other. And when you are choosing a Cadcam technology, a scanner, or any other part of it, like software or milling machine, you should pay attention to this point. And Dr. Al-Hassini tomorrow is going to talk for us about different scanners in market. As I told you, we have diagnosis and treatment planning for all the treatments that we do. For the actually diagnosis, we begin with intraoral examination, regardless of the technique that you are using. Then we make diagnostic casts in conventional techniques and take radiographs to see the, what is happening inside the teeth. Here, we have intraoral, after intraoral examination, instead of making impressions with impression tray and impression materials, we can use scanners, intraoral scanners. So you can have all the data from the teeth and adjacent tissues with intraoral scanner. You can at the same time design the restoration that you want, and if there is any problem, you can change whatever you want. Of course, sometimes you may need to have a conventional impression and then scan it. This is the capability of lab scanners, some lab scanners to do this, or you may even scan the cast of the patient, whatever you want. If you don't have an intraoral scanner, you can have scan the cast of the patient with a lab scanner, and then inside the software you can design and you can make your treatment planning. Talking about radiographs, we have a lot of progress in recent years because of the CBCTs. CBCTs are not only usable in implant dentistry. As you see here, you can diagnose the TMJ problems. And such a sharp view is not possible with conventional radiographs or MRIs. And it is a lot of progress in diagnosis TMJ problems. We also need jaw recordings. Always we send our casts with jaw recordings to the lab. In Cadcam system, in Cadcam technology, you can use intraoral scanners and scan the teeth in occlusion and send it to the lab. Or in more complicated cases, you may mount the cast on the articulator and then scan the articulator, or put the adjustment of the settings into the virtual articulator in the software, and then do whatever you want to do as you have planned. Also, we have jaw motion trackers, and they are new, not much new, but somehow new technology for seeing the motion of the TMJs and it can help in TMJ problems. It can be helpful for the patient in TMJ problems. We have also some cases that we want to change the smile of the patient. In conventional way, we take an impression, we wax up it and mock up it, and then try it inside the patient's mouth. But here with the smart design technology, we can do it in the software. Of course, we need a lot of photography of the patient. Dr. Ismaili is going to, today is going to talk about digital smart design, and on Monday, Dr. Atri is going to talk about mock-up and digital mock-up and wax-up, and comparing it to the conventional ways. So it is another benefit of the digital technology that we can use it. However, don't forget that to work with this software needs a lot of professional skills, a lot of skills, and it is not easy to use them. Like any other technology, we should learn how to work with them. But most important thing is to know when we can use them, how we can use them, whether it is usable now, or we should stick to the conventional way of treatment. Another technology that I saw it recently is the merging CBCT with a facial photograph. This is a technology that the CBCT takes the photograph at the same time and then superimpose them on each other, as you see. And this helps a lot because you don't have to take photographs in another session, and the angle of photographs and the position of the patient will not change during the taking the CBCT and photographs. So it is again a very long step forward. This kind of technology is helpful in surgery, in maxillofacial surgeries. As you see, you can plan your surgery with this technology, and it is very helpful for the patients. However, if you don't have such a technology, because it is so new, we can use digital model surgery instead of cast surgery. The cast surgery, when you do something with the cast surgery, if you know it, you have to cut the casts and put it in the new way that you want in maxillofacial patients when you have orthogenetic surgery. If you want to do it in the software, you don't have to make casts, and you don't have, if you want to change your treatment plan for any reason, you can do it in the software. So there's no need for another taking impression, another making casts. This is a kind of model surgery that you see here. Now, for the tooth preparation, up to now, we reached to the point that how we diagnose and treatment plan. Now, about the tooth preparation. Tooth preparation for the digital technology and conventional techniques is a little bit different. Why it's different? Because as you see here, if you have such sharp points, and the burr in the milling machine cannot make these sharp points, and it makes something like this. So you will have gap here. So in the digital technology, if you are using digital technology, you shouldn't have any sharp angles. And as you see here, everything is round. Also, because of the ceramics that we use most of the time our restoration is made from ceramics, and ceramics are not as durable as most of the ceramics are not as durable as the metal or metal infrastructures. So they are made round, and About and as you see here, one of the advantages of scanning is that at the real time, you can see what you have made, how you have prepared from the occlusion and from the axial surfaces. Is there any undercut there, or is there any, or the occlusion is not much good enough? It is not enough occlusion, and you have to prepare more. And Dr. Mostafavi on the Monday will go to talk about the tooth preparation and about the materials. With scanners, with Cadcam technology, you can use different kind of materials. Most of them for the aesthetic concern are ceramics. However, you can mill the cobalt, titanium, or other metals. But you have to keep in mind that for milling the metals, you have to send your scanning to the lab. You can't do this chairside. Zirconia is the other material that you have to send it to the lab to make the crown for you. But the others can be made, the other restoration can be made with chairside technology. Dr. Hassanzadeh is going to talk about the different materials that is used in, or actually different ceramics that is used in Cadcam technology. We have a stronger materials with Cadcam technology. As you know, zirconia is a strongest ceramic. It is very strong. It has high fracture toughness, and it can be used only with Cadcam technology. So here, as you see, we can have a resin bonded bridge with zirconia, but we couldn't have it before the Cadcam technology was introduced, because we couldn't use zirconia in this situation. And because of the Cadcam and milling machines, we have new treatment options like what we do in what is called endocrowns and restorations that it put on the crowns, on the root canal therapy teeth. And this option was not before because it was not easily done. It just could be done with metals or perhaps laboratory composites. Now with Cadcam technology, it is possible to have such new treatment options, and Dr. Siadat is going to talk about this option today. And here, of course, recently there are scanners that can scan depths to 10, sometimes 20, sometimes and perhaps 22 millimeter depth. They can scan it. It is not easy. Many of scanners at the time being are not able to do this. So it makes it possible to make posts and cores in whenever it is suggested. Is what should be it. The other treatment that you can use with Cadcam technology is the maxillofacial prosthesis. In the past, you have to take the impression from the patient's head during the surgery, but now you can design the processes that you want beforehand with the specificity of the patient, so it is so beneficial to the patient. Dr. Arshad is going to talk about patient-specific subperiosteal implants, something like this, and Dr. Niakan about maxillofacial treatments in the maxillofacial patients. We also have two kind of manufacturing. You know that we say Cadcam is the abbreviative of computer-aided design and computer-aided manufacturing. For the manufacturing, we have two techniques. Subtractive manufacturing is milling. You take a part of the material. It could be a metal material or some zirconia or other ceramics. But we have additive manufacturing. Mostly we know it as 3D printing. It means that you layer by layer add the material on each other. It has different techniques to the 3D printing or additive manufacturing. Dr. Payaminia on Monday is going to talk about additive manufacturing technologies. So be with us on this lecture. And because most of the time we have ceramics are used in Cadcam technology, most of the time we use resin cements or sometimes glass ionomers. Dr. Sadehpour on Monday are going to talk about Cadcam cements and cementation for Cadcam restorations. It would be very beneficial if you want to listen to it. And Dr. Otsi will show you some laminate veneers that is used, that is made by Cadcam technology. Now, let's see some treatments that have very good results by Cadcam technology. You see, we have a full mouth reconstruction implant supported patient. This is a temporary restoration. This is milled from pig, and as you see, it is completely difficult to do this with conventional technology. I think it is almost impossible. And here we have infrastructure, a Toronto Bridge. And as you see, we have a framework infrastructure. These are something like abutmented. And then the crowns are cemented over it. To make this infrastructure, it is very difficult to do it with conventional techniques, and it is much easier to do it with Cadcam technology. And this is the patient and the crowns inside the mouth. This is how it is made by Cadcam, and this is how it is made by conventional technology. Of course, it shows that the technician is very skillful, is very professional, but it is very hard, it is very time consuming, and if something happens, it would be very difficult to fix it. So here, the Cadcam technology has helped us a lot. Another patient is a maxillofacial patient. He has a very tense lip because it is also a graft, and no labial sulcus. When we were working for him, we encountered problems to continue the treatment, and when we wanted to give him provisional restoration, we find out that the direction of the implant is at the right angle to the direction of the crown. And this is because they couldn't put the implant in other way because their lips were too tense, and the graft that they have put under this graft had the direction toward the mouth. So it wasn't the fault of the surgeon. There was no other choice. And for us, also, there's no other choice than to using Cadcam technology like this to give the patient the something like a provisional bridge, but it seems that he must use it for a long time, and we repeat this treatment again. And this is a patient under general anesthesia, and we had to make impression at the time of general anesthesia because she was not cooperative. And I don't know. I hope Dr. Puya Sultanzadeh tells us about these kind of scanning. Is it possible to scan this kind of patients? Edentulous patients, something that we do during the complete denture making. If it is possible, it will help such patients a lot, and there wouldn't be necessary to take impressions during general anesthesia. This is a complication. As you see, the implants are too much close to each other and their angulation is not ideal. We managed to take conventional impression and for the cast. I wanted to know if it is possible. Instead of conventional methods, we use the Cadcam technology with scan bodies. And my lab did it on the cast. We have a very cooperative lab technician in the university, Dr. Mr. Mangoli. He is helping us in any situations like this. So he made two scannings and merged them on each other. But as you see, we have the line of a stitch. Because line of a stitch, I don't think it could be very accurate. Now, about the complication in implant dentistry, Dr. Baig and his collaborating dental technician, Mr. Leon Gerbo, are talking about overview of implant prosthodontic complications, prevention through planning. Tomorrow morning, it would be very nice, I'm sure. I hope you can come and attend his lecture, their lecture. Now about the education. Up to now, we were talking about the clinical cases. But digital technologies have something to do with education. Like what we have now, like webinars that are very helpful, in my opinion, they are very helpful. But we have 3D softwares that show you the pictures, animated pictures, and they are very helpful for learning. We have interactive dental education softwares. They are something that you can use them for, again, for learning something like morphology, like occlusion, like any other thing that you want. We have animated books, like pop-up books, but they are animated. For me, they are very interesting because when you talk about partial denture or something like that to the first year student, they don't know anything about the rest or class, or what is the difference between class 3 or class 1 or class 2. These animated books are very helpful for the students. We have also education softwares. We have, and in the preclinical training, we have simulations. But nowadays, with the help of digital technology, you can have the simulation. Also, on the monitor, you can see how you are making and preparing the tooth in real time. The other option is virtual reality. It means that you don't take turbine or handpiece in your hand with your hand, but what you see with the special glasses, as you are working with a handpiece, and also you feel like you are cutting enamel, or you are now reaching to the dentin. it has a haptic sensation. So, and these are another technology that can help in teaching the students for the works that we do. Also, there are robotic patients that if you don't have any patient, you can use them. Augmented reality is when you superimpose what you see inside the mouth with what you have in the CBCT, and it, like this one that you are injecting, you can see on the monitor the position of the needle in relation to the bone. This is a kind of augmented reality. And you can put the, with some softwares, even in the mobile or laptop, you can have a smart design for the patient. Thanks a lot for your attention. I hope you have enjoyed it. And my next guest is Dr. Rezvane Ghazanfari. And thanks a lot again. Now, Dr. Ghazanfari. Dr. Ghazanfari is our assistant professor in Department of Prosthodontics, School of Dentistry, Tehran University of Medical Sciences. Dr. Ghazanfari, we will be so grateful for you being here, and please start your presentation. This screen is yours.
Hello, everyone. I'm so glad to be here today, and actually, on behalf of Tehran University of Medical Sciences, School of Dentistry, allow me to extend a warm welcome to you. The topic of my presentation is possible workflow combination from entirely conventional to completely digital fixed prosthodontics. Actually, in this presentation, I will compare conventional fixed prosthodontics and digital fixed prosthodontics by the focus on digital impression and digital manufacturing. Let's start with conventional fixed prosthodontics. In conventional workflow, actually, after tooth preparation, according to the principles of tooth preparation, we make a conventional impression, and after that, we fabricate working cast and dies. In the next step, wax up will be done. After that, investing and casting will be done. And finally, porcelain adding will be done in order to fabricate the final restoration. Actually, the most common restoration in conventional dentistry in the field of fixed prosthodontics is metal ceramic crowns. So in summary, we do tooth preparation, then we make a conventional impression, then conventional gypsum dies will be fabricated. In the next step, wax pattern will be designed and fabricated. And finally, conventional casting and pressing in order to fabricate the final restoration. That in this case is metal ceramic restoration. In digital fixed prosthodontics, I mean the digital workflow, actually it's important to know that this workflow requires extra equipment, it requires extra time for learning, and of course, extra costs. But increased efficiency offsets this cost for both clinician and technician. One of the most important advantage of this workflow for the clinician actually, for the technician also, is the standardization of design and fabrication process. In this workflow, a wide variety of materials and techniques are available for both technician and the practitioner. And in this way, it would be possible to make a good choice for each patient individually. So in summary, in an entirely digital workflow, after tooth preparation, we have to make a digital impression by an intraoral scanner. After that, we have digital dies, then CAD pattern will be designed. And after that, CAD milling technique will help us in fabrication of the final restoration. Intraoral scanning is shown in this picture. Then we have digital dies, and finally the restoration will be fabricated. Intraoral scans are made into physical casts or left as digital casts for virtual designing of the final restoration. In the upper picture of this slide, you can see a printed cast actually. And in the lower slide, you can see a digital cast on which virtual designing will be done. Up to here, I defined two different workflows. Completely conventional workflow and entirely digital workflow. On the other hand, we may have combinations of these two workflows. Some steps may take place in conventional way, and other steps would be done in digital workflow. For example, after tooth preparation, you may make an impression digitally. After that, you may print resin dies. After that, you may fabricate wax pattern conventionally, and from this step, conventional workflow would be started. After that, these conventional wax pattern will be used in casting and pressing technique, and finally, the restoration will be fabricated. Another example of the combination of digital and conventional workflow is the way in which you prepare the tooth according to the principles of tooth preparation. After that, you make a digital impression. After that, digital according to the digital dies, you will fabricate printed patterns, and these printed patterns will be used in casting and pressing techniques in order to fabricate the final restoration. Actually, just the final step of this workflow is conventional, and other steps are digital. In the lower part of this slides, on the right hand, you can see milled wax pattern, both in full contour shape and also in a form of a coping, which may be used in the fabrication of metal ceramic restoration, in this case, a metal ceramic crown. On the left side of this picture, you can see a printed resin die for fixed prosthodontics, and the other steps, the continuing steps, the remaining steps will be done on this printed resin die conventionally. Now, in the next part, I will talk about digital impression in order to make a good comparison between digital impression and conventional impression. It's an important question to be answered, that why utilize digital impression. Actually, when we compare digital and conventional impression, digital impression is of course easier, better, and more efficient. By digital impression, patient satisfaction will be increased, and it makes it possible to evaluate your preparation real time just after making the impression. The other advantage of digital impression is that remaking the impression will just take a few seconds, and it's a very important point. Another thing to be considered is that digital impression will reduce the possibility of shrinkage. I mean, the dimensional changes will be reduced. By the use of digital impression, we can make a 3D printed cast, and this makes it possible to do the remaining steps in whatever workflow you want. In order to make digital impression, actually two main categories of digital acquisition units are available. The first group is sole impression system, and the other one is Cadcam impression systems. Actually, when you use sole impression system, these systems do not have the ability to design or fabricate the final restoration. But Cadcam impression systems make it possible to practice one day or one appointment dentistry. This is the example of 3M true definition intraoral scanning system. This is the picture of CEREC Omnicam intraoral scanning system. This is the picture of PlanScan intraoral scanning system. This is K-Restream CS, and these are captured screenshots of digital impressions of different scanning systems. About digital impression technology, we have got some important clinical points that should be considered in order to make a good comparison between digital and conventional workflow. Actually, the basic principles of making the impression in both workflows, I mean digital workflow and conventional workflow, are basically the same. If you cannot visualize the structure, you cannot capture the scan of that structure, and it's a very important point. So in order to make a good impression of the margins of prepared to, in some cases, I mean the finishing line, you have to retract the soft tissue by retraction cord or soft tissue diode laser. And this principle is actually the same for both digital and conventional impression making. Exactly like conventional impression making, you have to make the impression of the tooth and also neighboring tooth on each, at least one tooth on each side of the prepared tooth. Besides this scanning process, you have to make an opposing arch scan and also buccal bite scan. So it's not possible to make just the scan of the prepared tooth. And this is exactly like the conventional workflow. The most important contraindication of digital workflow is the inability to access the area. And finally, after the digital impression is done, the most common digital file formats, which is STL, I mean surface tessellation format, will be created in order to make it possible to design and mill the restoration. Digital manufacturing in the next step will be done. Actually, this part is the final part of fabrication of the restoration. We can categorize digital manufacturing technologies into two main groups. One of them is subtracting manufacturing technology, SMT, and the other one is additive manufacturing technology, AMT. On the right side of this slide, you can see the example of milling, I mean subtracting manufacturing technology, and on the left side of the picture, additive manufacturing technology is shown. It's very important to know that additive manufacturing technology is mostly used to fabricate temporary restorations nowadays. Subtractive manufacturing technology has got some limitation, and the most important one is geometry complexity. And it cannot actually produce all complex shapes. But SMT, I mean subtractive manufacturing technology, is the most predominant way or technique that is used for fabrication and restoration in fixed prosthodontics. Subtractive manufacturing technology may be done by hard milling. Actually, in the process of hard milling, material is milled out of the state in which there would be no heat treatment needed, and this is the final state of material in which its hardness and strength is in its final stage. And materials which may be used in this technology, I mean hard milling technique, are composite resin, composite ceramic hybrids, and some other kinds of ceramics. Hard milling is mostly used in order to fabricate single unit restorations. And finally, soft milling. This technology is mostly used when the material is not in its final stage. This technology is used for the materials that cannot be milled in their final stage because they're so hard or it would not be efficient enough. So prior to final densification, soft milling will be done. Now I have come to the end of my presentation. In this presentation, I briefly compared two different workflows, I mean conventional workflow and digital workflow, especially in fixed prosthodontics, and some examples of the combinations of these two workflows were defined. I appreciate sincerely your attention and interest, and thank you so much.
Thank you so much for your very nice.
Hello, hello, good morning.
Late in the night.
No problem. I just didn't hear you perfectly because I don't know, there was a little delay here. So
Okay. So let me to introduce you, or if you want, Dr. Sadapur introduces you.
hi,
Good morning. Hi, Kuya. It's very nice having you here. I know it's in the middle of the long weekend and you're in the middle of Memorial Day holiday, and it's our pleasure having you here.
thank you. You tell all the parties.
Anyway, what time is it over there?
Right now it's 10 to 10 at night.
All right. Great. And your baby is sleeping now, isn't he?
Well, I sent the baby and the mom to another city. So right now I'm a single dad at home.
All right, nice. Okay.
Congratulations on your newborn baby.
Thank you. Yeah, as everyone says, like it really changed my life, you know, like it's such a blessing.
It is, yeah, great. So Dr. Puya get his DDS certificate in 2018. Eight from Tehran Dental University, and then later on he moved to United States. He had a postdoctoral program at UCLA School of Dentistry. Then he joined Loma Linda University for additional 3 years advanced program in prosthodontics. Now he's running his private office. Also, he's teaching as a faculty member in Loma Linda. Now he does lecture nationally and internationally in oral implantology, prosthodontics, and cosmetic dentistry. And he has published numerous articles and book chapters in the field of implant dentistry, fixed and removable prosthesis. All right, go on, Puya. It's very nice having you, and we are all looking forward to listen to you.
Thank you, Dr. Sadapur. I appreciate the introduction. So it's such an honor, and thanks for inviting me and having me today, this morning. And yeah, I'm excited to share some clinical stuff regarding Cadcam technology, digital dentures, or at the end of this, I'm talking briefly about like partial dentures. My focus today is mostly like milk dentures, and mostly the company that's called Avident Denture. And this company was the first company that came up like with a nice system regarding milling dentures and Cadcam technology. So most of the cases that you see today, they're all from this company. However, like so many other companies nowadays, especially for the past 2 years, they came to the market and they are available to users. I mean, I don't know about Iran, but mostly in US and also in Europe. So let's start. So why do we like Cadcam complete dentures overall? It's because it made it possible to do clinical records in like a couple of hours in one appointment, and then the next appointment, potentially we can get the denture ready and deliver it to the patient. And potentially, like if you look at overall time, the number of sessions and appointments you're dealing with the patient, back and forth, impressions, records, pictures, this and that, it would be less clinical chair time for you. And on the other hand, you get it at the end of the day, you get a digital record that you can keep it somewhere or give it to the patient in a thumb drive, in a memory, or on a Google Drive or any kind of cloud system. So if the denture, God forbid, loses the denture, or like they broke it or anything happened to it, you can easily go back to the record and order it, mill it, print it, or whatsoever. So you can have the denture available even with a call, you know, so the patient even does not have to come to your practice. They call you, hey doc, like I lost my denture, I broke my denture, what should I do? I have a ceremony like in a week, so do me a favor, do something. I'm feeling so embarrassed. So that's digital technology can be so useful. So basically you go back, you retrieve the data, you print it or you mill it and you give it back to the denture and you bring the smile over again. So the digital dentures also could be mimicking the conventional dentures or the existing dentures that the patient already is wearing. So it's happened many times that at the school in private practice, the patients come and says like, Doc, I like my dentures the way they are. I just want the backup. I need this spare denture. I need a backup denture just to make sure I always have something, you know, like in my pocket in case happens or I lost them somewhere. So in that case, you can easily go and scan the existing dentures and make sure you can also do some improvements regarding the shade, shape, and you can send it to the company and they can mill it for you or fabricate it. And then there you go, you give it back to the patient. So there are other advantages of like complete dentures, Cadcam dentures is like the studies shows that they have superior fit. And the reason is because all of these systems, they use the milling systems, they use a pre-polymerized POC from conventional denture resin. So basically it's a POC, it's around polymerized resin, and they based on the scanning and everything, they design everything and they mill it off of it. So there's no basically shrinkage. And that's why many people argue that, do you really need like a posterior palatal seal? Do you really need to carve the butterfly in the back of the dentures? And many people say no, because you have a 100% adaptation. And as you see in this illustration, like in conventional dentures, we have the biggest amount of shrinkage in the back of the denture, posterior palatal seal in the palate area. And that's how you get sore spot or you get like food there. And that's why we carve over the cast conventionally to compensate the shrinkage for the resin. They also like they don't have any residual monomer, so because everything is already set. And on the other hand, they are less porous. There's no porosity because they're already like in high intense, like tons of pressure. They mill and they press these pocs of resin and they mill out of it. And their studies shows that they don't get colored, they don't get discoloration over time, and they don't get candida albicans, they don't get bacteria adhere to it. So it's very hygienic and they don't smell as other old dentures. And this process, it could be used, like the Cadcam technology could be used for regular complete denture, immediate dentures, or immediate like conversion prostheses, for hybrid prostheses, a lot of things that I'm gonna explain it. And this is one of the tons of other studies that one of the few ones, the first few ones that it published by a good friend of mine and my classmate, Dr. Goodacre, that he compared different types of dentures. They evaluated the conventional pack and pressing, pouring, injection molding, and Cadcam, which was the Avedon that time. And they, as you can see from this color mapping, you will see that more you see green and yellow or yellow to green means like a better adaptation. And even like this illustration shows like it has such a great adaptation. Another study done in Buffalo in New York, they evaluated different types of surfaces, and they could say the Avedon denture, they had almost like zero candida albicans like adherence to the surface. So wear testing is being done also in these type of dentures because many of them, they are monolithic, means like the teeth and the denture base, they're all milled together. So in that case, the whole thing is really strong. And then the wear pattern that they studied is like so low in compared to any other like denture teeth. So what are the disadvantages of Cadcam dentures? Honestly, in US, the biggest disadvantage, the first thing comes first to the mind of all the clinicians, like it's expensive, because it requires a lot of like a PVS material, polyvinyl silicone material, because we don't want to have the material distorted because sometimes we ship it and it's costly. And then also the trays and the components that come with it, they're not that cheap. You know, it's a new thing, and for sure everything which is new is going to be expensive. Many companies, they advertise as a 2-appointment treatment, but many times it's not, and it can up to 3 or 4 appointments. So when we are talking to the patient recently, or actually for the past few years that you're more acquainted with the technology, is we never promise them it's going to be a 2-appointment denture. We tell them, okay, we do our best. However, it may take 3 to 4 sessions, but the advantage, we just focus on like the accuracy, strength, the smell, the discoloration, all the other things. And yeah, expensive. And also it has a learning curve. And the other drawback of that one is not worldwide available. I'm not sure about Iran, but even like in some states here, it's not very popular. And honestly, like I don't have like a real statistics, but I think it's around maybe 5 to 10% of the clinicians, they actually use this technology yet. So right now there are many companies that fabricate that. You know, Avident, as I mentioned, they fabricate it. There's Dentka that they have 3D printed dentures. We have like Palette Digital Denture. There's some German companies that are involved in that. Ivoclar is one of the other big ones into this in this technology. Glidewell is making that. So there's so many of them. So it's just a matter of like the concept, you know. But if I say in the US, which companies they are more popular and they're now like ahead of others, it would be Avident and Ivoclar, the companies. So let's see how these things are done. The applications that we do for these dentures, as Dr. Farid was like asking, is like, yes, we can make obturators actually with those. They are used for regular dentures, immediate dentures, for temporary dentures, obturators, as I mentioned, over dentures. You can make the dentures with pre-cuts, and it's good for immediate loading and a lot of application. You will see some of those cases. And also sometimes the patient, they come with an existing like hybrid case, and you just remove the denture teeth and you keep the bar, and then you process the bar over those. So Avident comes like overall in 2 different types. One of them is like traditionally they mill the base and they mill the teeth, or they have the prefab teeth already, and then they have it in the database. So they mill the base, and the technicians in the company, they one by one stick the teeth over the denture base. The other one that they have available in higher prices would be the XCL1, XCL2, which is the teeth and the denture base like all milled together. So this one is really useful for immediate loading, for implant supported like dentures, and it has less stain, less streak line, and it's also very popular for the oral surgeons. When they want to do something, they're making sure that the denture is not going to break, so they're really strong compared to conventionally processed dentures. Now that you're looking at these pictures, maybe like I will tell you a side note that I'm not sure, I haven't encountered or read any articles about it, but in Loma Linda, all the edentulous patients, we treat them with Avident denture, with all digital dentures. And only like if they're both arches in edentulous. If the patient has already like one arch dentate or a partial denture or something, we only do conventional. But if both arches are edentulous, we only do Cadcam or digital dentures. What I've noticed is, I mean, at least for Avident, for Ivoclar, I've noticed that their aesthetics is a little better over Avident, but for Avident, sometimes for patients that are really high demand regarding aesthetics or high smile line, or they're very picky about their look, it may not make them happy. So that's the only thing. And for example, in the right side picture, this denture is really pretty, but it still is not 100% translucent, or kind of, you know, it has some drawbacks in the like monolithic ones. In the 2 separate ones, like the 2 phase one, which means they mill the base and the denture and they stick the teeth into it. Cosmetic is a little better compared to monolithic. However, in monolithic, in the XCL2, they cut back the teeth and they layer another resin over it. So cosmetic has been improved, but it's still like, I would say 3, 4 out of 10. I can tell that the cosmetic is really high and good, but half of them is questionable. So for example, this patient that came to the clinic, existing dentures are worn down, patient asking for a better denture, better fit, and better chewing efficiency. So what it could be done, at the first session, you can make a putty index from the denture. So basically you make a quick cast off of the intaglio surface of the denture. And then based on that, you can do measurements there, and you can make your trays, or you can make custom trays, or there's some trays available in the US that they are thermoplastic. Basically, they are in wax, and high temperature wax, you soften them with torch or with like hot water, and you mold it on the cast, or you can also mold it in patient's mouth, just like a border molding. And then when they got cold, it kind of formed like patient's mouth. And then you can do your impression with that. You can use polyether, you can use like PVS, or you can do polysulfide. And just like this impression. And then when the impression done, there is another record needs to be done, and it's called Anatomical measuring device. And that one basically dictates the vertical dimension, centric relation, the lip support, midline, occlusal plane, smile line. So everything that you do at the wax trine and tooth trine, you can do with this device. So I'll show you in details like how it works. It's a kind of like quick introduction to what it is. Now, many people say, okay, how about the tooth size? So they have a kind of mold, like in kind of on a clear printing that it has small, medium, and large. So you can stick it over the denture, existing denture, or that AMD device. And if none of them fit perfectly, then you can draw with Sharpie over it, because at the end, the lab will scan them. You can stick those with like a flowable composite or super glue or whatever, like make it stick to the AMD device. And this is how it looks like. And we always like accompany all the records with some clinical photos. So basically those three are the required records that you submitted to the company. So yeah, it's a digital denture, but still you need to have some PVS impressions. Now, there are some few trials and case reports that they had done fully digital workflow, especially for maxilla, and actually Goodacre, Charles Goodacre and Brian, they published that. And yeah, it's doable. So you can basically stretch the lips. You can do the full scan of the upper and lower. But remember, it's not 100% accurate, because we're talking about the selective pressure points and border molding. So what they do, they scan the whole jaw, and they send it to the company. They mill the trial denture. They make a prototype. And over that prototype, again, they check the fit, and they might be able to, again, reline it, and then they rescan it, and then they finalize the denture. But direct, fully digital with no PVS has been done. And for maxilla, like for sure it works, but it's still for mandible, because of the retromyelid space, retromyelid space, the buccal shelf and everything. It's a little hard to do that. So all these records will be sent to the lab, and the lab will scan everything. And then based on that, they start designing the denture, and they do the occlusion. They send you the preview, you evaluate the preview, the occlusion, and at the end, they mill the base, denture base. If you do the conventional, like a milled Cadcam denture, they stick the teeth to the recesses that has been like milled over the base, and then they glue it and they polish it and deliver it to you. That's how it's done. And then at the time when you use pre-IP to the paste, this shows that how much contact we have, and really good retention off of the upper and lower denture you get. Then this is the before and after. So there are different options. So when you talk to the company, you can do different things. You can ask them, okay, I want a little texture or high polished. You can ask them, okay, I want Rogue or not. And it depends on your patient feedback, or prefer like your preference as a clinician. Many times I ask them to put Rogue for me, because the patient have a better feeling over that. It creates a little stuff for the tongue, and they have a better pronunciation over some certain words. You can also ask for posterior palatal seal. You can have it or not. As I said, there is no shrinkage. That's why you may not necessarily need like a post stamp or like a butterfly design on the back of the denture. So you can request that. And also the flanges, when you do impressions, you can ask them, you may hear light, you may hear like tall or some other things. So you can play with it. And you can also ask them to just give you the base, they give you the base, and it's delivered. It's going to be much cheaper. And then you send it to your conventional lab, and they will set the teeth over that base, and they process everything. So you can have their service just for milling you the denture base, which is the most important part for the denture. And then you can do everything else conventionally. They can add colors and staining. You can ask your lab even do that, because basically they're regular PMMA, and then they can do anything that they can do unconventional, just like this case that they're adding some characters, some like veins and everything to make it much more natural. So let me go a little more details about the different methods of getting these dentures. So patient comes to you and asks for digital denture, or you discuss about digital denture, the advantages, or the patient, especially like some of the patients that keep breaking their denture, and they don't want like thick denture, they don't want heavy dentures. You can take advantage of the Cadcam dentures because they're, again, superior strength regarding flexural strength or compressive strength. All these properties, they're very advantageous. So you can duplicate your denture, and you can do impression with that duplicate, and you can get the bite or get a new bite, and then you send it to the company. The company will evaluate the design, and then they send you the preview. You check everything and refabricate what patient asked for. And this is like a denture that it looks like inside and outside. And this is how the patient smile would be, and the patient is super happy. The other method of fabrication would be using a good fit. There are some patients, they come to your practice with no dentures, and you want to and they are really in time constraint, and they really want to get it done fast. So the company makes something is called good fit denture. Basically, the picture on the left-hand side you see is a pre-made denture base with some teeth on it. They come in 3-4 different kind of sizes, and they are prefab. They're prefabricated dentures, but they are thermoplastic. Basically means if you put them in hot water or you heat them, they are moldable. So you can do border molding with them, and you can do impression with them. So we do tissue stuff like that, and then we do impressions. We mark the post stamp, butterfly design, and this is what the company will receive after. And then you say, okay, the midline is here. You can even draw the teeth outline where you want the smile line, where you want the midline, and all the other things. And at the end, they will scan everything, and they will fabricate you denture. So just like this is the virtual design, and this is the final outcome. And the patient's super happy. You see, in this case, the dentures are really good, very natural, patient super happy. The other thing is you can, for immediate dentures, this one takes time. So you have the patient's cast, you can scan the cast, and also you can set some teeth over the cast, get the bite, just like this one. They set the teeth, and then you scan the cast, because I know many clinicians right now, they have a scanner in-house. You can send it to the company, and they start giving you the digital preview. The blue one is the existing one that they scan, and the white one is the new design, the white teeth. And you can play around with the teeth position for immediate denture. And you say, this is the occlusal plane that I want to have, and this is the final outcome. And then you say, okay, now it's ready for either trial or printing. The milling. And that's it. And they're gonna fabricate you. Now, what if you want to do this immediate denture with implant placement? Perfect. So you do the CT scan, and you submit the data to the company, and also they work with other companies too. So they merge and superimpose the denture design with the CT scan, and you can do digital planning for your implants. Implants are positioned based on the cast, based on the CBCT, and based on the denture that they have the data. And then you start doing the surgery, or your surgeon will do the surgery. And the beauty of the Cadcam technology, and even Avident denture or Ivoclar, is based on your planning, they give you a denture for the day of surgery with some pre-cuts and with holes in it. So the day that you put the surgical guide in the patient's mouth, there are already some pre-cuts and there's some holes. You place your implant exactly as planned. And at the time of delivery, You just put it in patient's mouth, you pick them up and you break from the cutting points, and there you go, all ready, just like this case. So implant placed, teeth extracted, and denture was picked up intraorally with multi-unit, and the hole, just like there as it was planned, picked up. And then the yellow one that you see, they are like PVS material, and they've been sealed temporarily just to make sure everything good, and then later they can be sealed. And this is like just a temporary denture. And this is the time that the patient was dismissed from the surgery room. And the whole process would be like much shorter than a conventional one. This is another case, like this is another technique to actually obtain the record. The patient comes like in this beautiful teeth setup, like a very healthy teeth, of course. So all of them are planned to be extracted. So severe periodontal disease, all the teeth extracted, and this is like a fully digital workflow ahead of time. And teeth were upper and lower extracted as a reduction guide was used. Implant like location will place were determined. Implant were placed through the guide. Implants placed, as you can see in the pictures, even implants look happy. And this is the both arch immediate dentures like placed just after placement. And some adjustment done regarding the occlusion, and patient left, and the rest of the prosthesis was fabricated like around like 6 months later. And the patient super happy. As you can see, it's an immediate like smile makeover or full mouth reconstruction per se. So let's talk about like AMD, or an anatomic measuring device that I previously.
Yeah, I have a quick question.
Sure.
Do you hear me? Would you go back for a second to the previous case? So you pre-made the denture and then you fix it in the mouth after the surgery. The
Yes.
lady with the nice setup, yeah.
Yeah, I think I went too far back.
No,
Yeah.
I think, yeah,
Yeah,
three or two,
you
perhaps
just-
two slides before, just two slides before.
Yeah, I clicked too much.
It's too late and you're too tired because of the big mistake.
Lag in my slides, so that's fine. Now what? Let me just skip and go a little faster like this.
Sorry, interrupting you.
Yeah, no worries. That's fine. Actually, I like it better than like just speaking alone, because monologue like is kind of boring. Yeah. So yeah, dentures are already made. They scan. I just skipped those parts because of the time, but dentures are already made. So when the patient just came for the surgery, like all these things were planned ahead of time, and then the dentures that they were made, they were like loaded immediately. The same
Right. So basically, in the day of scanning, you pre-made the acrylic denture ahead of surgery.
ahead of, yeah, like not this. I mean, when you scan the mouth or scan the cast, it takes time. It takes around like 3 to 4 weeks to get the dentures back. And then you do that. So these dentures are not made immediately unless you have 3D printer, because actually I was attending like a couple of meetings like for the past few weeks, and all printing companies, they are doing that. So basically within an hour, within an hour and a half, honestly, you can print your dentures, but printing is still weak and is still inferior regarding mechanical properties to milled dentures. But you can do that in office while you're doing the surgery. You can print your dentures and then you pick it up in patient's mouth.
Great. So either way, you have the denture ready in the day of surgery. And because in the previous case, I saw the full denture for the maxilla had a base, but in the day of delivery, you ground the whole palatal plate and it was totally implant supported denture.
Yes.
So for this case, the same.
Yes. Like what we do in US mostly, we all do screw retained dentures.
Right.
We don't do cementation either for the temporary or conversion or for the final. We always do screw retain. We don't do like cement retain.
Yeah, if you go to radiograph, we can see the temporary cylinder, and I see the radiograph for this case. Yeah. Yeah, this one. And I can see it's a very tough case, and you had two angle abutments, multi-unit angle abutments on the terminal implant on the maxillary arch. Am I right?
Yes.
Interesting. And you choose the
Use multi-unit abutments like 17° or 30° to correct the angulation, make them parallel, make them exactly go into your denture, and then you pick them up, and then there you go. You're all set. You're in business.
Great. Do you mind if you tell us which type of implant did you place there?
They are Noble Biocare. The maxillary one are active.
Noble Active.
Noble Active, and the mandibular, I think they are like Noble Parallel.
Great, great. And you, did you extend it to the second molar on the arch, or like?
So what we usually recommend for conversion or immediate is extend it up to first molar.
I see.
And we don't extend more unless like the patient is like dentureless or there's no opposing teeth, or the opposing denture is like, the opposing dentition is denture. So that's what we do.
Great, great. But still, it's a time-consuming procedure after in the day of surgery. Fixing.
It's usually time-consuming, and sometimes we dismiss the patient and ask them to come the day after.
Right. Great. Very nice case. Great job, man. Thank you.
Thank you. So AMD devices, or the anatomic measuring device, it's a device that was patented by Avedon company. So basically what it does, all we do with denture base and resin, which means like adjusting the lip support, vertical dimension is higher, lower, you can do with this one. So this has a stud, and if you're familiar with the Gothic arch, basically the concept is like Gothic arch tracing. So you, by screwing, tightening, or loosening up, this is stud, the blue round thing, it goes higher and lower. So basically you adjust your vertical dimension. And also like in the opposing arch or lower jaw, you can have a plate and then ask the patient to go forward, backward, and side to side movements. So what happens with these movements, basically, you draw a kind of like arrow, and that arrow, it tells you that the tip of the arrow, which is looking forward, is the CR record, is this CR point. And you make a dimple with your burr, and then you lock the position of these two together like that. So this is the opposing, this is the lower. And then how you fixate those AMD devices is just like the PVS impression. So first you put it on the upper jaw with PVS, so it stabilized it on the upper jaw, then on the lower jaw, and then you ask the patient to do these movements. And then how you put the marking on the plate, you can ask the patient to put some PVS adhesive, or you can use some carbon marker or Sharpie marker. And when the arrow is marked and you see that, you make a dimple, and then there you go. You do the measurements, make sure the vertical dimension, lip support, and everything good. You stick your teeth, you mark them, you ask the lab what size you want, you take clinical photos, and you do like a bite registration to capture the whole inter-occlusal, like inter-arch jaw position, and then you submit that to the lab. And then the dentures come back, they come like this, and this denture has a little class 3, so the dentures were set kind of like edge to edge position. Then if there's any planning for a surgical guide or surgery, you can utilize that, because as you know, we all do our full arch restoration with like prosthetic in mind, with the prosthetically driven surgeries. So you can do the surgical technique like a guided surgery, you scan the denture, you scan the cast, you do the planning, everything done. And you can also pre-cut, as you can see, and based on your question, we always like extend the conversion process, and not over like a second molar, but we just end it by first molar, and sometimes in premolar. I just did like a case like a month ago with a periodontist regarding the implant surgery, and I did the conversion up to second premolar per surgeon's request. And you fixate those. Multi-units are placed, and then the temporary abutments over the multi-units were put there, the holes there, so they're sticking out. You adjust it, you cut them, you pick it up intraorally, you toss the rest of the unused full denture, and then you finish and polish, high polish surface, intaglio surface, occlusion check, and there you go, it's all done. And this is the converted denture on the lower, and the still maxilla would be a regular denture, and this is a patient's smile. So in summary, these are the kind of impressions you're looking for. So you still, like if you do for lower jaw, we would like to do border molding, and we prefer a heavy body PVS material because it has some consistency and strength. Like when you submit it to the company, due to the thermal condition, nothing happens unless you have your scanner, you scan it, and then you email them to the company. They also come up with a ruler that it tells you the interpupillary line or horizontal line, and you read the numbers for them. You can mark the midline. This is the AMD device. You can take all these pictures, send it to them, and then you can do with the arrow, and then the company will scan everything together and they fabricate you the denture like that. I'm going a tad faster just to make sure I finish in time. I have 4 more minutes almost left. So this is a day of surgery, the same concept. The denture was duplicated. The surgeon used that as a kind of guide to position the denture, the bite, and then the holes. Everything was sent back with the multi-unit, and then they milled the denture off of it just like that. This is the upper, and the lower will come after, like this. And these are the final prosthesis actually that the Evident can fabricate for you. So what they do basically for the final prosthesis, they first mill the base, mill the bar, and then they scan the bar, they scan the denture, they scan the tissue, and then they design everything, and they can do wraparound design different ones. And this is like a comparison, like the monolithic in the lower and the commercial regular denture on the upper one. And these are the different bites, and you see they have pretty good occlusion. So regarding the designs, as I mentioned, what they can do, they mill the bar first, and they fabricate a denture, they hollow out the denture, and they embed the bar into that denture. And then they seal the bar with like regular resin. So the only part which is not fully milled or Cadcam is the area that is wrapping around and is kind of conventionally milled one. And you can also, just like a Montreal design, you can have the highly polished metal exposed, so you don't have to cover it up. And we like this design for the lower jaw. We like the wraparound design for the maxilla, just for phonetic issues. Right now, Avadent has come up with new technologies, new designs. And what they do, if you go to their website, you can see that. They do all these hybrid prostheses in different designs. They can do wraparound, they can do in a kind of 3D printed bar that they incorporated into the denture all at once. So it's crazy. I don't know. The technology is kind of confidential. They can do Montreal bar, so the bar is exposed. They also have like an axillary set, which is relineable, and they have like some studs. I have not used the first and the fourth option, but they're very expensive, honestly. They take around like 6,000 to 7,000 to fabricate each prosthesis. So you need to charge a patient a pretty good amount of money. And this is like another case. So now many people may ask, okay, are we about to use their system? Well, you can use like your conventional system and then send them back and they scan. Like this case, I did it. The denture, the occlusal plane was off. So I send the pictures, I modify it with VAX, I send it back to the company, they send me the trial, and this is the smile, and they correct it. This is the final one. And the occlusion pretty darn good, no adjustment needed. Another case, the trial came back, and the patient loved it. And there's another one, the patient was a denture inverter, not happy with the design. We did follow the design. And this is like a trial denture, but what you can do, they print this base and they put the teeth in wax. So basically in your trial session, you can move these teeth around, you can go upper, lower, like, or more front, more back, and then you do bite registration on a wax plate, base plate, just like conventional method, send it back, and they mill you the denture. And the quality not the best, but yeah. And then for this case, the midline was off. You send it, they design it, and this is the denture that you receive. So since I don't have that much time, I put 2 videos regarding the whole process, but basically you saw everything. So I will skip these 2 videos just because of time, but you can also see a lot of things on the website. And this is like for Ivoclar that they do that. You can also use Cadcam technology in partial dentures. And this is actually one of my research.
Yes, sorry, I interrupted you again.
Sure.
One of our lecturer, he has delay, so we have, if you need, we have another 15 minutes time. So if you want to present the details, we are fine.
Of course, with permission from Dr. Nokar, if you don't mind, Dr. Nokar, we take the time of the break because we can see Dr. Sultanzadeh very soon, and it is very informative lecture. Please, Dr. Sultanzadeh, don't mind.
Give us more details, please.
So I have 5 minutes more, or 50?
But whatever you want, whatever you want.
Okay, so maybe this video is good. I don't know if you've seen it from Ivoclar. It shows how they fabricate the denture. So I will be silent so you can just watch it. It's for around like 2-3 minutes.
It means that they have both teeth and the denture in one block.
Yes.
The innovative Ivotion combines a proven cross-linked PMMA tooth material with a high-quality denture base material. The state-of-the-art manufacturing process enables the direct chemical bond between these 2 materials, resulting in a stress-free, homogeneous transition with consistently high strength. Ivotion is a truly monolithic disc, but the real innovation is found inside with its revolutionary shell geometry. Shell geometry design consists of a 3-dimensional tooth and dental arch framework, with each surface containing the prosthesis for the upper and lower jaw. In order to develop this geometry, a large number of proven in-use full dentures were scanned, analyzed, and brought to a common denominator. The result is the revolutionary shell geometry. The design accommodates the creation of dentures for just about every patient, regardless of jaw shape and size, allowing for a truly monolithic denture to be digitally manufactured. This unique configuration works like this. The shell geometry defines the transition between tooth and denture base material. And using the intuitive 3-shape design software, the teeth will perfectly align with the gingiva, whatever the size of the patient's palate. The blue guide determines the perfect alignment of the dentition to the gingival margins. Starting with the Ivotion Tooth Library and the Shell Geometry Guide, complete customization is possible. The teeth can be moved as a group, or individual teeth can be adjusted to suit the technician's needs. During the fast, uninterrupted milling process, a prosthesis is milled with high precision. Once milling is complete, the denture only requires polishing, and the manual work is reduced to a minimum. Ivotion is revolutionizing the world in the production of monolithic digital dentures, and is...
Yeah, and then the Ivoclar company, basically, they also give you some tools so you can do with photography and scanning. They have digital articulator, so they are really like making great improvements in the aesthetics of the dentures, and it's really like impressive what they are delivering to the patients. So since my topic was about removal prosthesis, I thought maybe it's good to have a little conversation, or just like talk about like the application of Cadcam technology in our partial dentures. again, like at Loma Linda, we do for pre-doctoral clinic, all our partial dentures are 3D printed. So basically is cobalt chromium alloy, which is laser 3D printed and based on the cast. So we do conventional impression, we do the design, we prep the cast, we prep the mouth, we make the impressions, and then the lab will scan the cast, we do the design, just like what you see here. So the cast design, based on the design, we make sure the undercuts, the amount of undercuts, we put everything into planning, and then when it's done, we submit it to the company. It's called 3D RPD, one of the few companies that they do the 3D printed cobalt chromium, and they fabricate the partial denture, the framework, and then we try it in patient's mouth and we design it. And then when we approve it, then we conventionally process it. So again, since we have time, I can show it. And this process just direct metal laser sintering, or DMLS. And then the powder would be in like a big sink or like reservoir, and laser will like layer by layer add the metal to each other, adhere the metal chemically in such a high temperature. So we can use cobalt chromium, titanium, or any others. They do the design. So this is like the same technology in industry they do, but also in dentistry, they take advantage of that. Layer by layer. So each layer will be stacked on the previous layer, and they melt together, and then they blend it. And the study shows like actually it's going to be a very strong and solid denture. It's not a weak one. Then there's no void or there's no porosity in it. And this is how the partial is actually made. So there's so many in just one series. Like these machines, they can accommodate 36 to 40 per manufacturing. They're running the device. After that, they do some heat treatment over that. And this is how it comes out after the tinting. And they cut this stuff. Sometimes they do twice, sometimes like once, and they just increase it. And this is how it turns before finishing and polishing. And the lab technicians just do hand finishing and polishing, and they give it to the clinician. So we do the try-ins, and then we conventionally put the teeth on, and then we deliver it to the patient. So I didn't study because by that time it was kind of new, and I evaluated the accuracy of these kind of partial dentures that we 3D printed. And this article was actually, I used it for my master thesis too. And I looked at different areas regarding the major connector, minor connector, anterior strap, posterior strap, guiding place, and the rest seat areas. And I evaluated 4 different groups, and there 2 groups were conventionally made, and two groups were Cadcam. And I used like the 3D printed models, and also I used like fully digital workflow. And at the end, surprisingly, like it was shown that conventionally made partial dentures were more accurate than 3D printed. However, based on the numbers that we got, they're all clinically acceptable. So it doesn't mean that if you do digital denture or digital partial denture is not gonna fit. Actually, they do really fit and we've shown and we've proven that in our like clinic that we do tons of those partial dentures over a period of like years. But like when you come to like details and numbers, yeah, like the Cadcam is still a little weaker than like regarding accuracy to conventional. And one of the reasons is like by that time that I was doing this study, it was the slacking of the digital technology and the scanning technology. And right now, with improvement in the scanning technology and the accuracy of the devices that we have available, these numbers are much more lower and they're really comparable to what we have. Dr. Farid asking about obturators. This is also another article that I published. It was a case report that I did on a young guy, unfortunately had to do hemimaxillectomy because of the cancer. And yeah, it utilizes the Cadcam technology to make this obturator. So what I did, I prepped the teeth and I did the conventional impression, but also I did the scanning. But I noticed that because I was doing the research, I was kind of like in the process, okay, maybe like conventional would be better. So however, because of this design, it was very hard to do fully conventional. So I did the impression and then I scanned it, and then we fabricated partial denture with 3D technology, 3D printing technology. So the base metal, the partial was 3D printed. And then we conventionally set the teeth, and I set the teeth, we did the aesthetic trying, and that was the result before and after. And that was it, and patient was very happy. Also, there is a technology called D-Light, and what they do, rather than conventional finishing and polishing, they merge and submerge the partials in a kind of like a metal beads with some ions and some environment that removes these spikes, removes the sharpness of the metal, and make them blend in. And actually, this is going to be published soon by one of my residents, and it's actually the second phase of my research that we evaluated this technology, and it shows that D-Light, this technology, provides much smoother and much better surface regarding the polishing, and it improved to some extent the fit of the digital dentures or the 3D printed partials. However, still conventional dentures are conventional partials, metal partials are more accurate. But at the end, it was concluded that when you do conventionally finish and polish the partial dentures, you have more metal loss, and you have the higher chance of inaccuracy in the seat adaptation to the rest area. So that was one of the other things. And having all these slides and presentation, that concludes my presentation today. And thank you for very kind attention. So I'm so happy, grateful to be graduate of like Loma Linda, UCLA, and Tehran University. And as Americans say, I'm a proud alumni, and I love all these schools, and hope we continue this collaboration. Thank you so much.
Thank you so much, Dr. Sultanzadeh, for always supporting us. We never forget it. And let me, before Dr. Nakar starts his presentation, to ask two questions, very short and very quick. Do you use scanning in your department for complete denture patients?
We do, but not on regular basis, because we still see like with like regular impressions, you get a better and accurate result.
And are the 3D printed frameworks strong enough in
yes,
you?
Very strong. If you look at studies, I didn't put them in, but if you look at the study, they're pretty strong. Like printed metals are really strong. Because of the
gap between, there's no gap between layers that are deposited?
That's the advantage, because casting always there's a chance of porosity and voids, but with 3D printed technology, you don't have that. That's how it makes it more homogeneous and more strong.
Thank you so much, Dr. Sultanzadeh, for everything. And I think that
let's ask audience if there is any question. I don't see anybody ask any question here. So I go ahead, and regarding the accuracy in the paper that you published, I saw it was written that gap between the major connector and the rest sits with the teeth was around 50 microns.
Mhm.
It is actually very accurate. I mean, even in the PFM crowns or ceramic crowns, we do accept on the supragingival area around 40 microns and the subgingival area around 120.
Well, actually, yes. So what I considered a good fit was something from 50 microns to 311 or 311 microns. I consider that as a kind of good fit based on the literature. So for conventionally like processed partial, like the regular cast partial dentures, that number was around like something from 70 to 100, 150, and a little more or less. And for Cadcam ones, like 3D printed partial dentures, was around like 200, some of them 300. It was a little like more gap, but it's still like all of them were within the clinical fit, within the clinical acceptance. That's what I said, like clinically, both of them are performing pretty good, and we have tested both of them and we're very happy with the results.
Right. And you mentioned about the hybrid bars that recently they made the bar, the milled bar with the denture at the same day, at the same sequence, and it's very new. And also you mentioned about the cost of the preparing this type of hybrid bar. I do remember it was at the day of the milling bar came out, it was like $250 to $300 per each hole or each implant. But you mentioned about 6,000 to 7,000 for the whole prosthesis.
More.
You're mentioning, I think it was surgical guy. That fee is, it's not about 100, it's about thousands. Right now, if they mill the titanium bar for you, the lab, they charge you around like 2,000. If they mill the full arch zirconia, they charge you around 2,000. Now there are some labs, they give you a package and they charge you A to Z, like for example, from the denture itself to the final product, like they give you 2 to 3 products. They give you the denture, they give you the prototype, they give you the full arch zirconia or full hybrid, and they charge you around like 4,000 to 5,000. Usually like 5,000 is the fee that they charge you. And Avedon charge you per arch around 7,000. So it's like, it's way more expensive.
Right, but since you skip the abutments for charging for the abutments, for the multi-unit abutments plus the abutment on the top, if you add these total cost or on the from the denture, I mean that maybe it's a kind of reasonable price.
Not yet.
Not yet.
Not yet.
All right.
Yeah.
All right.
He knows better.
All right. Perfect. Thank you so much. I don't see any questions coming up, so we move on with the
Other than ours.
You can use it for patients at a school because they get some discounted fee from the companies. And
Right.
in some cases, especially if they're new cases, the companies give you free trial, and also the patients get discounted fee, and the school doesn't get that much of benefit or profit out of it.
Right.
So it's still, they're not like widespread, they're not like very common to use. Yes, there are like few people, like I know like one doctor in Florida, a few doctors in California. Even in US, because of the cost, it's still not very common, but they're really good products to use. I know many people, they use wraparound design on Montreal bar, but I haven't seen still people using the first and the fourth one when they're left and right.
Great.
Thanks
We really
a lot.
enjoyed your lecture, and I'm sure everybody took advantage of your very recent informative lecture. So
Dr. Sarapur doesn't want to let you to
go.
leave us.
Yeah.
To keep you
Since
here.
the baby is not around, so we can have you more. So thanks a lot. It was great having you here, and looking forward to see you again
In
back
person
home.
here.
Yeah, in back home in Tehran University School of Dentistry. And any question? So
Thank you
we
so
move
much.
on with the next lecturer, And
See you
we
soon,
all
Dr. Sultanzadeh.
say
Inshallah.
good night to
Good
you.
night. And
Take
our
care.
next lecturer is Dr. Nokar,
All right.
the head of Prosthodontic department.
Dr. Nokar, he's the head of the Prosthodontics department. He's the board man since 10 years ago in Advanced Prosthodontics. And we are going to have a lecture. The topic of the lecture is an overview of fabricating Cadcam restorations. Dr. Nokar, if you hear us, please move on.
Thank you very much. Hello, everybody. It's my pleasure to be here with you today. Title of my lecture is an overview of fabricating Cadcam. Sorry, please wait. I sharing the video. Okay. Okay. Okay, thank you very much. Okay. Title of my lecture is an overview of fabricating Cadcam restoration. In this presentation, I would like to show you how to design an endocrown using Cadcam technology. Okay. Okay. I go over here to select software icon. We are running version 4.4.4, as you can see on a screen. Okay. I adjust the sound. Okay. The first step is add to new patient. I'm gonna type the patient last name and first name in the name tab. You can go through and put in the date of birth and the patient ID. If you want to, also you can put in the dentist name. In the next step, we are gonna add a case, choosing inlay as endocrown, selecting the tooth that we are going to be working on, maxillary right face molars, and then select the milling unit. On the select material tab, selecting manufacturer name, the Insply and the Celtra Do material for our restoration. Then we hit OK. In the next step, on the selecting restoration type, I select only as endocrown. We have two options below the design mode. This area, design mode. For each tooth, I select biogeneric in the individual. Next, we are going to move forward to our scanning screen. So here now you can see the camera is active device. Let's see, here is what we call the Omnicam, and this is one version of the equation unit. Welcome to my office. First, we are going to scan the upper jaw, then lower jaw, and finally buccal scan. We start scanning from occlusal view of the selected tools. Slowly move the Circ Omnicam in the occlusal direction from distal to mesial. Rotate the Circ Omnicam between 45 degrees to maximum 90 degrees toward the buccal or lingual. The camera does not rest on the teeth or the gums. Scanning the occlusal surface, palatal, anterior palatal surface. After completion the scan of upper jaw, we click on the lower jaw. I'm going to the lower jaw folder. We are working at to number 3, so I need to scan basically this little segment of the jaw. And we don't need to scan the whole thing. I just need the opposite teeth and to make sure I have a clear image of the buccal. The head of the scanner rotate to the buccal and lingual about 45 degrees to scanning the lower jaw. Scanning the occlusal surface, buccal surface, and lingual surface of the lower jaw. So at this time, I need to activate the buccal folder, and now we are gonna go ahead and scan the buccal. The buccal scan tells the computer how two teeth are orientated next to each other or opposite each other, makes sure the patient is biting correctly with both sides together at the same time. So you have to guide them a little bit. After the scan is completed, the next step, the software going to calculate the accurate data in order to produce 3D models. It takes about 1 minute. Next, we are going on to the model tab. Yes, okay. At this point, we can edit these models. All right, so I'm going to use the cut tool, and let's just say we want to trim off some of this extra data, starting with double click for trimming extra data and continue with single click and ending by double click. Trimming the extra data of upper jaw, continue. After editing upper jaw, I'm going to edit lower jaw. Starting cut with double click, then continue with single click. Trim the extra data of the lower jaw, starting with double click and continue with single click and ending with double click. Okay. The next step is the buccal bite registration tab. In this step, we evaluate the occlusion. If it isn't correct, we should go back and scan the buccal bite again. Evaluate the occlusion. And the next step is set model axis. This step is the model positioning step. We have got anterior, premolar, and molar teeth regions. Dragging model on the U-shaped area. Adjusting midline. Paralleling incisal and occlusal path with horizontal plan. On the next step, we are going to edit the jaw line. You have to position the dots in order to shape the arch form actually, and you have to put the blue circle on the selected tooth. The next step is trimming the select tooth. Then we are going to draw the margin. Margin finding is actually very simple. I can either click to manual mode or I select auto margin mode and edit it later. I selected manual mode, okay. Then I'm just gonna start dragging, and you can see that blue line follows the margin pretty well. So we are going to go ahead and go to the next step. Defining the insertion axis. The insertion axis is aligned as vertically as possible to the occlusal surface. The next step is checking parameters. Spacer parameter is used to increase or decrease space for adhesive. Marginal adhesive gap parameter is used to adjust width of gaps on preparation margin. As you can see, we can set other parameter too, including occlusal milling offset parameter, proximal contact strength, occlusal contact strength, dynamic occlusal strength, also margin ramp angle. So we are going to go ahead and go to the next step. The next step is Morphology Design tab. Automatically, the software is going to propose a restoration. And the next step is positioning. I'm gonna start with the position and rotate tool, and I'm gonna rotate this crown so that it match a little better. Then I'm going to use the scale in order to make appropriate contacts and the contour. You can grab the entire occlusal or mesodistal side of the tooth and move it. Rotate toward the distal and adjust the position of the crown. use a scale tab and adjust the contact area. Edit restoration is the next step. We have three important tools which can be used to add up, remove, and smoothen the surface. Now, I'm going to choose click on this tab, and now I'm going to choose a smooth tool. There is an option for changing size and strength of tool, smoothing the palatal surface for better polishing and glazing. And choose the Add tab and change the size and strength, adding the on the occlusal surface that is thin. And then I select again a smooth tab and smoothing the cusp and slopes. Change the size of a smoothing tab. Okay. Evaluate the occlusion. Produce restoration. I'm going to hit next. All right, so you see adjust mill position. Tab in below the screen. Rotate the block for adjust the position of a screw. You can use the positioning tool to move the block around the restoration, turn it, and determine the screw location if you need to active upper jaw and evaluate the position of the restoration in the block ceramic. And start milling. As you can see, milling, a machine is measuring the block size. A circumcision machine is 4-axis device. The MCXL can be used for both wet and dry processing. On the screen, you can see the approximate time needed for milling, about 11 minutes, starting the restoration at a rate of 20 micron slice, which is impressive. You can see a medium grit diamond, bare grinding silk rod block. Now that we are done, next step is staining of the restoration. We can use a brown color on the proximal surfaces and in bottom of occlusal pit and fissures. We can add a blue stain on tips of cusps to mimic enamel and translucency. Violet is used on restoration and it increases translucency. Also, we can apply brown and orange stains on buccal and proximal surface apical to the contact to mimic discoloration. Brown stain, apply on the occlusal surface and depth of the fissure and pit. Brown stain we can use for staining the proximal contact. Okay. After coloring is completed, we are going to place the restoration into furnace, select Spitfire. The temperature rises up to 800 to 850 degrees depending on the glass ceramic material. On the screen, you can see the approximate time need for glazing is about 10 minutes and 35 seconds. The next step is trying and cementation. We use dual Q cement for cementation. Treating fitting surface of Celtradu by HF. After washing and drying, applying silane on the surface. Treating a selected tooth. Applying bonding agent. After washing and drying, mixing dual Q resin and cementing restoration. This is the final result. Thanks for your kind attention. Also, if you have any question, you can contact me through my email address. Thank you so much.
Thank you so much, Dr. Nokar, for your nice movie and presentation. We hope our audiences have enjoyed it. And again, sorry for bothering you and starting your presentation a little bit later than it was due. And if our audiences have any questions, please write in the chat box. And if not, so we can start our next.
For Dr. Nokar, if there is one quick question, if you need to add some porcelain on the final restoration, definitive restoration, which type of ceramic do you use? I mean, since as far as the baking temperature, that would be different. So would you advise us which type of porcelain we can use for it?
Okay. Porcelain that we can use, it should be compatible with the original material. For Celtradu material, we should powder that is compatible with this material. But in the office, we can't this opportunity because this foreign aesthetic is designed for the only and this device has a pre-program, and we can change the degree for crystallization or glazing.
Yeah, that's correct. Thank you so much for your answer. And I think because we are late, we may ask our next lecturer to come and to talk for us. Thank you so much again, Dr. Nokar.
Thank you so much.
See you later in
Okay.
other programs, inshallah. Now,
Thanks a lot.
Now,
for the next lecturer, we do have Dr. Siadat. She's full professor of the Advanced Prosthodontics Department in Tehran School of Dentistry. Her topic is Cadcam restoration of endodontically treated teeth. So we do have Dr. Siadat in the lecture room. Please move on.
As you know, the endodontic treated teeth are very common in the dentistry, and so we have a problem how to treat them. Sometimes we have to do post-on core crowns, and recently we can do endocrowns with the Cadcam techniques. Actually, I think in the past we only could do it with either metal like gold and casting, or with heat press technique.
Right.
But now we can do it with Cadcam technique too.
Right, a type of milling technique, like we can use zirconia ceramic material rather than the traditional concept of making casting post and crown or the press technique. So
the good news is that some of the scanners have the capability to scan inside the canals. I'm not sure they are very common in the market, but they I have heard PrimeScan can scan
yes, it's
as
doable.
long as
It's doable. So you can scan the tooth, even the pulp chamber, even the
inside the
access
canal.
cavity. So get enough retention for the crown. So by this way, we do prepare the tooth less than the conventional techniques. And the best part of it is that it's very fast. So you can do it in one session, building up the whole last part of the tooth. And the finishing is as good as the ceramic crowns.
And because it is
functional and long-lasting restoration.
Because it is tooth colored, it is more aesthetic than the
right,
others.
exactly. They have there's more satisfaction with the patients, and the result is fantastic.
Yeah, and I think because of the cementation with resin cements, they are long-lasting, also more durable than other.
For sure, yeah. For
composite resin.
Recent cements, since the resin cements, the solubility is almost zero. So that's one of the reasons they are very successful and they last for a long period of time. Usually for a crown, single crown, the literature said the longevity of a single crown is around 8 to 10 years. So if we do have this longevity for the end crown, that means it's success. So this type of restoration, it's a good option in the office. I do recommend every clinician to try this technique and make the 5 sessions, 5 appointments for the patient to 2 appointments. I mean, 1 session, you do the preparation and the final impression, and then the next session, you can deliver the restoration and restore the last part of the tooth.
And it seems that it is better for the tooth if the amount of last tooth structure is not too much. We can use it as a conservative treatment.
Right, because we do prepare less than conventional crowns. So we just restore the last part. So we do have to see that here. Do you hear us?
I think there is a problem with the there's a problem with the image.
Internet is very slow, so
no, I think for us it's okay.
the camera maybe.
Yeah, I think there is a problem
with the camera. That do you hear us?
Yeah, I'm here.
All right.
You can see me. Just
Yeah.
Yes.
Right now, you're fine.
No, yeah, it's okay.
Please go ahead.
okay. Let me a second, please.
Yeah, please. Can you start your presentation? Yeah. Thank you so much.
Okay. Hello, everyone. It's my honor to invite in this webinar as a speaker, and I will share with you my experience about Cadcam restoration and endodontically treatment options. And after finishing the presentation, I will be pleased to answer any questions if there are any. Thank you. Okay, when a tooth has a good remaining structures in the buccal, lingual, and proximal side, after root canal therapy, it's not suggested to prepare these remaining tooth structures for casting post and complete crowns. With this type of treatment, the intact remaining parts of the tooth are destroyed, and it's also not conservative. As you see, we have intact tooth structure there, and we can save them with make a good decision. We have some disadvantages with the routine cemented casting post. Placing the post require an additional operative procedures, as you know, and preparing a tooth to accommodate the post entail removal of additional tooth structures, and the post can complicate or preclude future endodontic retreatment that may be necessary. And we may have some problem and limitation for accessing into the canal. Maybe we have the calcified canal or narrow canals, or maybe we have a fracture instrument in the canal, then maybe I can't using the casting post or fiber post in this situation. For this situation, introduce the endocrown that's used for Bindle and Mormon. This kind of restoration is an adhesive single partial restoration that made with monolithic ceramic restoration, and it can anchor the pulp chamber and with the banding, and it's very conservative than the post and core. We have some indication for this kind of the restoration when interocclusal space is very limited, and when our canal is calcified or narrow, or we have the fracture instrument, and when our remaining canal were more than 1/3 of the crown, then at least we need 2 millimeters in height and weight in the remaining crown of the tooth, and at least we need 1/3 of the crown structures for using this kind of the restoration. The longevity effectiveness of the endocrown has been completely proved, especially in molars. But they have to be used with caution in premolars, and the case selection in the premolars are very, very sensitive and important. We have some contraindication with this kind of the restoration. When our patient have some poor functional habits, or if we can't have complete isolation for the saliva, because this kind of restoration is according to the banding. And when we have less than 3 millimeters depth in pulp chamber. We have some advantages with this kind of the restoration. This restoration is very conservative, and when we operative a crown lengthening surgery on tooth, some problem might occur for both of the tooth and the patient. Patient would have to spend more time and money on the treatment. Also, the crown root ratio could be compromised. And on the other hand, adjacent teeth would have a high chance of becoming sensitive due to bone and gingival loss. In addition, the aesthetic of the tooth might also be compromised. When endocrown, contrary to full crowns, finish line is very far from the gingiva in most structure of the teeth. Sometimes in proximal side, our finish line is near the gingiva. Then gingiva is very healthy and it will be very good for the gingiva. And this kind of the restoration is very fast, and you can deliver this in 1 or 2 visits to the patient. Making processing of endocrowns are very fast in contrary to routinely casting post and crown. You can do it in 1 or 2 sessions. If you have the Cadcam technology in your office, you can deliver it to patient in 1 visit session, at least in 1 or 2 hours. It's related to kind of the ceramic. And risk of the banding can increase if we haven't good isolation or patient have poor function. Risk of tooth fracture can increase if tooth isn't enough thickness in buccal or lingual side. There is a contraindication when large amount of coronal structure is missing. We have a range of ceramics that you can choose it according to your experience and according the strength of the ceramic and aesthetic. You can choose one of them. The most popular ceramic that can you use for this kind of restoration is lithium disilicate, as a Emax cat or press, you know about it. And the hybrid ceramic can use for this kind of the restoration too. The zirconium restoration is not good for this kind of restoration because you can't have bonding in the zirconia restoration. IPS Emax is a Cadcam lithium silicate glass ceramic, and you can have this in very little minimum thickness, less than 1 millimeter for the occlusal veneering, or when you don't have enough space for the occlusal reconstruction. And it's very excellent result and very high customer satisfaction with this kind of the ceramic. This ceramic have in different translucency, shade, size, and you can choose it according to your experience and according to tooth color for the patient. The flexural strength of this ceramic is more than 574, and it can suitable for 1 or 3 units situation, and it's available in blue block. The manufacturer block is blue violet and is famous blue block, and is available as a Cadcam block and press fit. If you use your lab, you can using press fit, and it can be less. It's not very expensive. The Cadcam block are more than expensive than press fit block ingots, and it's partially crystallized because the bearer can introduce and prepare the block, and after the furnace under vacuum, it can gauge the strength more than 574 and gauge optimum translucency. Another ceramic that is popular for this kind of restoration is zirconia reinforced lithium silicate. The famous of them is Self-Radu. This kind of block have 10% zirconia, and you can hand polishing or glazing. Both of them is in-handed, and if you use polishing, the flexural strength is 210 megapascal, and after glazing, it gained 370. As you see, Self-Radu is very good, and the marginal integrity for long-term clinical confidence is very good with this kind of the ceramic. We have some rules for preparation of the endocrine, and we can review some of them. There are the pulp chamber must be 6-degree divergence for preparation in axial wall. If you increase the divergency, you may lose the thickness of the tooth, and if you lose this thickness, you have the failure in the endocrine, and your bonding will be damaged. Then it's very important your divergency wasn't very more than the 6 degree. As you know, we have some undercuts in orifice of the canal. Ignore this orifice, because if you want to eliminate them, you increase your preparation, and you lose the remaining teeth. And as I said, this remaining teeth is very important. Then you can use flowable composite for block cut this undercut, or ignore them, and after that reshaping the ceramic before the cementation. May you have some undercut around the structure of the teeth. Don't ignore surrounding undercut, and you have to remove them, because you need a very good passive insertion, and in the passive insertion you need to don't have any undercut. For increasing the mechanical retention, at least 3 millimeter depth in endocrine pulp chamber must be exist. Less than this can use for the preparation of the endocrine, but maybe failure. Maybe you have the failure for the banding, because you need a banding and the micromechanical retention. Both of them is important. And a good remaining structure about 2 millimeters in buccal and lingual side, or if you have the structure in proximal side, is very important, and you need them. Omit unsupported enamel in depth margin if you have, but if you use deep margin elevation technique, you can use this unsupported enamel for bonding the composites for increasing the margin in proximal side. If using this, as you know, you have to use rubber dam if you want using this kind of the technique and support the proximal side of the teeth. Around all right angles, it's not acceptable any sharp edges in around of the structures. And convex cavity bottom without additional preparation is acceptable for this kind of the restoration. It can increase the retention of the endocrown. At least 2 millimeter reduction, occlusal reduction, it can be good for contouring a very good occlusal aesthetic for the crown. If you don't have enough space, 1 millimeter occlusal reduction will be okay. But in 2 millimeter occlusal reduction, you can have a very good aesthetic cusp and grooves in the occlusal side of the crown. Simple design preparation is preferred. Complicated design is not acceptable, and the sitting of the final restoration will be very hard. Then omit all of the any angles or line angles and smooth all of them. According this preparation, no floral effect acceptable. Then it can be reduced strength of the final restoration. After complete preparation, don't forget finishing and polishing the preparation area. As you see, the articles show when you have ferrule, the strength of the final restoration can be restored. In brief, we need 2 to 2 millimeters occlusal reduction, and all of the margin needs butt margin, butt joint format, no sloping, no any shouldering. Pulp chamber preparation must have 6-degree tapering in all walls, and orifice undercut okay, or you can using the level composite, and prefer finish of margin in enamel supragingivally. You don't need go in under gingiva. No engagement of canal or reduced wedging, because the chamber can be good for the mechanical retention, and no engagement. No angles or edge shoulder preparation with round inner edge count and or chamfer preparation. And enamel wall less than 2 millimeter teeth should be removed if you don't use the deep margin elevation method. And depth of the cavity should be at least 3 millimeters. Okay. For making an impression, we need recognition the finish line. We have some methods for recognition the finish line. The routinely famous method is using retraction cords. As you know, we have retraction cords in different thickness, and you can use it according to the thickness of the gingiva. Another method is laser diodes for using it, and using silicone barrier or electrosurgery. Using electrosurgery is very sensitive because it can damage for the patient and the for bone. Sometimes after using electrosurgery, may patient have the recession of the gingiva. A very good method is using silicone paste. We have two famous silicone paste for retraction cord, Expasil from the Care company or Ostrogent from 3M company. Both of them is very useful for retraction and stop the bleeding. Both of them are very good. You can inject them into the sulcus and push it with a micro brush. Stay for 2 minutes, and after that washing, and you can recognize the finish line very good. And if you have any bleeding, the bleeding can stop after that, and you can take an insertion. If you use digital insertion, you can start with device scanning and scan the mouth of the patient, both of the jaw, and recording when the patient occlude all of the teeth together. After complete the scanning, you can planning in the computer. If you don't have the equipment, it's not important. You can use the conventional method, insertion method, and you can use the additional silicone and take an insertion and send it to the lab, and your lab can scan the cast and complete all of the manner in the computer. For planning, it's very easy in the computer. At first, you set the jaw for the models and position it in the good. And after that, draw margins, draw the finish line, the position that the final restoration will be set on it, and accept the insertion access or path of insertion. And after that, you need set some parameters like the thickness of the cement, occlusion, proximal side, thickness of the margin of the crown, all of them you set. And after that, you select the anatomy of the crown from the catalog and set in the position and check the occlusion, the proximal side, and all of them. You can check it. And after that, you can set in the virtual blocks, and in the preparation device MCXL, you can use the original block with the color and this good size according to your teeth. And after that, you can prepare in a preparation machine, MCXL. At first, check the size of the block. Is it correct or not? And okay. And after checking the size of the block, it can prepare the endocrown from the block. This block is the self-radu. As you see, this block is according to the color of the tooth. But the IMAX crown is not, the crystallization is not complete because it's very hard, more than self-radu. And after complete the preparation, it will go to the furnace and complete the crystallization. Okay. After almost 7 to 10 minutes, you can have your endocrown, and you can glaze and stain it, and it can go to the furnace and complete the crystallization. And you can see it can be a very good aesthetic, good anatomy, good accuracy in the position. As you see, this and the crown is not complete the crystallization, and after complete the crystallization, it can have the true color. Okay, after complete the crystallization, you need to deliver the ceramic to the patient. For delivery, you have to follow some rules. It's better using HF for the preparation the ceramic. If you use Emax, you need using 20 seconds apply HF in the ceramic and brushing and movement. After that, if you use Celtra-Do, this time must be 30 seconds, and if you use another one like the feldspathic ceramic or Vitamark 2, Ceric Block, all of them is 90 seconds, and Anatomical and Empress CAD using 60 seconds for using the HF. After rinse and dry, it's better using the acid phosphoric for removing the extra salt, and it will be better for the bonding. And 30 seconds using this and rinse and dry. And after that, you can use the porcelain bond, 1 or 2 coat, and waiting for 60 seconds without curing. As you see, apply HF, rinse, and another one. If you use zirconia for this kind of situation, you have to use sandblasting for increase the banding. As I told you, and you know, the zirconia can't have enough banding to the dentin and enamel. Then you have to use zirconia for the zirconia sandblasting, and after that you have to use zirconia prime. In the other side, in the mouth patient, you have to use phosphoric acid for prepare the structure of the tooth, and after that rinse and dry, and you need using the bonding into the tooth of the patient. Don't using any curing in this situation, and after that you need using the dual cure resin cement. Dual cure resin cement is better than light cure because the thickness of endocrown is very high, and dual cure is very better, and you will be sure that the curing is complete. Then inject the dual cure into the pulp chamber and sitting the endocrown slowly in the position. After about 5 seconds, because you use the dual cure cement, the primary setting of the cement will be done, and you have to remove excess cement before curing. Okay, you use the sound for the removing extra cement, and use the dental floss. Please stop the endocrown in the position and move the dental floss in proximally side and put it out without removing the occlusally, because your curing is not complete. And after removing all of excess cement, you can complete the curing of the endocrown for 40 seconds in every side of the tooth. As you see, in premolar and molar, you can use it. But as I told you, in premolar situation, it's very important that you select a very correct case, because it can be complicated in premolars. And in this situation, when we have half of the crown, you can use it in sectional, but you have to select the good color. And another one in the position. In the end, we follow these 4 rules for success and longevity of the endoprone. Careful selection of the case. All of the cases aren't good for this kind of the restoration. Correct preparation of the tooth without undercut, without unsupported enamel, without any angles, and precise selection of the restoration and bonding material. All of them are very important for having a very good success endoprone for the patient. Thank you for listening this presentation. If you have any question, it will be my honor to answer them.
Thank you so much, Dr. Sadat, I hope everybody have enjoyed it, and we hope to see you again on other programs. Because we are actually behind our schedule, we skip the question and answering because I don't see any, of course, I don't see any question in the chat box. Is there any question? I don't. It isn't. So let's say goodbye to you, especially because Dr. Salapur is not here to ask questions. Yeah. So let's say goodbye to you. Goodbye, and thank you so much.
Thank you.
So everybody, we have a short break, about 15 minutes, and then we will be with you again. So see you in 15 minutes. Goodbye.
At 11:13?
Yeah, 11:13 or 11:35.
All right.
Thank you. In 2 minutes, we start our new presentation. So thank you for being with us from the beginning to now. It is very, we are very honored. The international part of the Tehran University of Medical Sciences School of Dentistry welcome you again to our program. Our next session is about digital small design, and our lecturer is Dr. Pejman Esmaili Fallah. He is he has a degree of DDS and certified master in aesthetic dentistry. His topic is principles of smart design in CAD softwares. As you know, recently smart design softwares are very common in actually for treatment planning in cases, laminate veneer cases, or cases that want to change their anterior teeth. However, working with this kind of software is not easy. You should know all the tips and tricks actually. So today, Dr. Esmaili is going to talk about these tips and tricks, and how to start and to continue with smart design softwares. As I know, at least we should have a lot of photographs from the patient in the front view, in lateral views, and from even up in smile and in order with teeth shown or without the lips together. So it seems that working with digital smile designs is not as easy as it seems, and it's a very skillful hand and professionality, perhaps a professional technician or and the doctor who guides the technician. So Dr. Esmaili, we hope to have you here now. Okay, Dr. Esmaili, hello. Welcome to our program. We can hear you. Please talk a bit. Now we can hear you. Yeah.
Okay.
Okay. Thank you so much. Please start your presentation. The screen is yours.
Just a minute, Dr. Farid.
Yeah. Okay. Okay. Take your time, Dr. Esmaili. It's okay. You know, the live presentations have sometimes have these problems because changing the laptops and PowerPoints is difficult. I see some familiar names here, like Asuma Awudu. Asuma, how are you? I hope you are okay. And Dr. Dodgar, nice to see your name here, Dr. Dodgar. Yes, thank you. I'm fine too. Thank you for joining our program. Hope see you in person here next time, Asumo. So great. I remember, I think you have been here last time too. Okay. Again, hello again, Dr.
Hello
Ismaili.
again.
Yeah.
Just a moment. I share my screen.
Okay, okay. We can wait more to see your slides and your presentation.
Good day, everybody. This is Dr. Peshman Ismaili, and I appreciate from Dr. Farid for inviting me to this program. Today, I want to speak about smile design issue. Designing a smile is a hot topic these days, but every lectures talks about DSD, Digital Smile Design, or softwares. But before or in the past, there is knowledge about designing a smile, and we should pay attention to this knowledge and these scientific issues. Like many things comes from media, the smile design or designing the smile comes from Hollywood or media. When we back to the history, Dr. Pincus, for the first time in 1930s, he made acrylic veneer for this actress and changed the smile. This patient comes to my office for smile enhancement or changing her smile. You can see some alterations in her smile. Before starting the designing a smile, we should have a biologic view. Means that in 2002, Dr. Pascal Magnier published his book, and in his book, there is a nice diagram about biology, mechanics, functions, and aesthetics. In this situation, when we respect biology, we reach mechanics, function, and aesthetics. And in 2005, Dr. Dawson published his book, and the title is Functional Occlusion from TMJ to Smile Design. He believes that smile design is a biologic treatment and we should respect functional and stable TMJ. Another mindset, we should have restorative view than prosthodontic view. Means that in the left picture, there is an implant. This implant has mechanic and function. If the patient is low lip line, the aesthetic probably is acceptable, but there is not healthy. There is an inflammation in his or her gingiva, and it is not biologic treatment. But in the right, you see the central. This central is an implant, and I can make papilla and curvature of the gingiva, and the white aesthetic is acceptable. Another furthermore mindset is stable concept. A stable concept means when our treatment is biologic, the treatment is stable. From 2010 to 2017, you can see nothing nothing is changed, and you can see all things is stable. Another new aspect is biomimetic dentistry. These days, when we talk about biomimetic, everyone thinks about filling or composite or other things. But biomimetic has a huge meaning, and we should study the nature and then copy the nature and makes our restorations or do our treatments. Until now, we should have 4 mindsets. One of them is biologic view, then restorative view, another one is stability, and the last one is biomimetic view. Another things we should pay attention is universal language. What is universal language? Universal language is a common communication between two people in any nations or gender or races. These images can show you my treatment plan procedures and my abilities without any talking about my treatment plan. This is the power of image or media. And a smile has a lot of name, but it is a universal language, and we can transfer our feelings to each other or any other. And some feelings like love, laughter, joy, happiness, caring, and as the like. For having better success, we need communication. And good perception needs for better communication. And a smile can give us self-esteem and better good perception. In one article in newspaper in New York, the people who has a nice or pleasing smile, they can easily hire and get a job. In another article from AACT in 2013, 89%, near to 90% of people come to our office for attractiveness and for self-esteem. Now, we know that the smile is a universal language. And what is smile? A smile is not fashion or whims, and is the same for all peoples. All peoples needs a pleasing or pleasant smile. Another definition for smile, the smile is a most visible part of the face and can communicate between two minds of the people. In another articles in the newspaper, you can see the smile is an unconscious communication, and I think the name of the smile is biologic communication. In 1840s, Congress of Physicians in Paris, they defined the smile, and they said at that time, contraction of muscles make a smile for us, and the contraction of these smiles is related to our expression or feelings. If I want to name the smile muscles, in this slide I arrange the name of these muscles, these 7 muscles: zygomaticus major, zygomaticus minor, orbicularis oculi, levator labii superioris, levator angulioris, risoris, and nasalis. And the number of muscles and the emotions of persons or of people different from each other, and can affect the emotions, can affect the type of contraction of muscles, and it is different from person to person. I think the smile is a unique contraction for each people. For the first time, Dr. Irvan Smigel said about the designing a smile, or his definition is, designing a smile is a plastic surgery without scalpel. And then he talked about the muscles needs a proper or a good supporters for contraction. When we meet the peoples, we can notice that they smile about 47%. Our method for designing the smile is proportional smile design. Before starting the proportional smile design, we need another mindset. This mindset is facially generated dental aesthetics, or we should pay attention to out and then in. Out means face, in means oral aesthetics. We should notice the face, and after that we should notice the oral aesthetics or oral area. For generating facial aesthetics, we should know our orthodontics, periodontics, restorative dentistry, maxillofacial surgery, and as the like. And the smile is created by the group and some of the fields of our some fields of dentistry, like orthodontics or restorative dentistry, can make the proper or pleasant smile. Our evaluation methods is objective. Objective smile evaluation is our technique. For objective smile evaluation, where we should start from lips, facial muscles, skeletal structure, or occlusion. We don't know about the start point. For objective smile evaluation, we need to evaluate all smile components. We need unlimited time factor and measure relative tooth dimensions. If we respect these items, will lead to predictable results. For objective smile evaluation, we should know about the photography, and I think every dentist should know about dental photography because we need dental photography for predictable results, because photography make for us unlimited time factor and relative tooth dimensions. Then dental photography is essential in evaluating a smile. Photographs provide unlimited time as well as the ability to measure the dimensions and proportions of the teeth. The camera of the lens should be parallel to the facial plane of the central teeth. And we need a good lens about 100 millimeter and 35 millimeter camera, and the magnification should be 1:2 because we don't have any distortion. Our photos should be adequate depth of field, proper lighting, and minimal optical distortion. And the camera should not be too close because the teeth are distorted. From now until the end of this lecture, I use 5 view. 5 view means facial image view evaluation. We use photograph as a facial image view evaluation. 5 view. The meaning of the 5 view is not cast view. In figure A and B, you see the cast view, and in figure C and D, you see the facial view or 5 view. We need to analyze our facial and teeth in 5 view or figure C and D. Our method is proportional smile design. For designing the smiles, there are many rules for the designing about zenith, dimensions, the contact points, and as the like. But we should pay attention to key points. 1. Some rules might be broken, and the another one is no one's smiles ever follows all the rules. For the proportional smile design method, we should use or utilize 5 view, not cast. because when we talk to person or people, we see facial view and five view, not cast view. For designing an ideal smile, where should we begin? This is the most important question for us. Incisal edge is the starting point, and the incisal edge should be parallel to interpupillary line. In this patient, you see we realign the photos firstly and then draw the two lines, incisal edge and interpupillary line. But some patients has canted incisal plane. What should we do? What we should do? In this situation, sometimes we can make the parallelism between incisal edge and the interpupillary line. Sometimes we cannot do that. For this situation, firstly we should make a mock-up for patient and check it, and check in natural head position, because natural head position is affected to our decision for accept this cant view, or we should realign the canted incisal edge to the parallel to the interpupillary line. Proportional smile design, as before I talked about, from facial to the oral aesthetics. We should we divided the face into three sections: forehead, cheek, mouth. Forehead from pterygoion to nasion, for cheek, nasion to the subnasal, and the mouth section is from subnasal to menton. In this patient, we do the analysis of her face, or rule of thirds, from hairline to the nasion, and from nasion to the subnasal, and then from subnasal to the menton. In the sagittal view, you can see this rule of thirds, but there is a good point. The mid face of the central incisor should be perpendicular to the occlusal plane when we see. Third step is the rule of thirds in lower thirds of face. Divide subnasal and menton into equal thirds. Incisal edge should be adjunction of superior and middle thirds. In this patient, when we analyze the face, you see the incisal edge in the superior thirds of the inferior of the face. In some patients, we lost the VD, lost the vertical dimension. Before increasing the VD, we should analyze the face, and if we see the losing of the VD, we can analyze the face, and then we can increase the VD, and this is a good reason for us. Proportional smile designs some factors like appearance. First of all, we should see the overall of the face and the oral aesthetics of the face, and it looks good or not. And then some points for checking the incisal edge. One of them is phonetics. Two of them, M and E, M and E positions are statically positions, and S video and F and V videos are dynamically situations. M position show us incisal edge the relationship between incisal edge and upper lip. The E position show us the relationship between incisal edge and lower lip. Lower edge position, and the S video shows us the lower edge position relative to palatal cingulum or to the upper incisal edge. And the FV video show us the incisal edge position relative to lower lip. M position is a statically position, and you can see in this patient less than 2 millimeter, you can see the show of the incisors, central incisors, and the number of these show is about 2 to 4 millimeters. In E position, you should pay attention to the incisal edge position, relation between incisal edge position and lower lip. In this situation, in the E position, likely touching to maximum 2 millimeter from lower lip during a smile. And the gingival display is about maximum 2 millimeter. And teeth fills about 70% of interlip space when saying E. When Dr. Ed McLaren combines M and E positions and makes a rule 42.2, the 4 is maximum show of the central incisors in M position, or the name is central display. 4 means central displays, and the 2 is gingival display, and the number of show is maximum 2 millimeters. When the patient in M position, the maximum number for showing the central is about 4, and in E position, the maximum showing of the gingiva is about 2 millimeter. And 0.2 is a distance from lower lip in E position. The distance from lower lip maximum is about 2 millimeter. Is about maximum, you can see in this photo, about 2 millimeter. And S video. S video is the most important video we need it because the relationship between lower edge position and palatal cingulum or the upper incisal edge. S video shows us the envelope of function. Please see this video.
61, 62, 63, 64, 65, 66, 66.
When this patient 66, you see the forward movement of her mandible. In this patient, you can see the forward positions in S video, and you can see some chippings in central incisors. I learned this S video and the importance of S video from Dr. McIntyre in US.
سی تا 40 بشمار. 30 31 32 33 34 35 36 37 38 39 40. حالا 66 رو دوباره چند بار بگو. 66 یه بار دیگه. 66 یه بار دیگه.
66 forward movement, and you can see the reason of these chippings. FV video is a dynamic video and dynamic movement of the lower lip. In this video, you see the relationship between lower lip and incisal edge position. The FB position is slightly posterior to wet dry line.
51, 52, 53, 54, 55, 56, 57, 58, 55, 55.
And these phonetic tests from the denture time, and when we want to make the denture, always we use these for these tests for trying our dentures. The third option is occlusion. In this time or in this lecture, I cannot talk about occlusion because I don't have enough time, but we must notice the occlusion factor. And the fifth step is determined the vertical midline. Two options for defining the vertical midline. One of them is philtrum of upper lip, and the other one is the line perpendicular to the interpupillary line. In this patient, you can see the vertical midline, and I draw it from the philtrum. This view, the name is 12 o'clock. This view is introduced by Coachman for checking the midline. Until now, if I want to summarize these previous slides, the first we should analyze the facial by rule of thirds. Then we can determine the incisal edge by the rule of thirds in inferior sections of the face, and until now we can determine the incisal edge. And if we can add the incisal edge, we can do mock-up and do the test again. And until now we should draw the incisal edge and determine the incisal edge. And before I said the designing a smile is a plastic surgery without scalpel. Then, like a plastic surgeon, we should rule of thirds analysis for the face and for the lower section of the face, and we should notice the whole body. Later, I'm talking about the whole body and smile. Until now, only we talk about the relation and the relation. Now I want to talk about dimension and how to determine the dimension of teeth. In edentulous patient, the ratio we should find out or determine the ratio between face and teeth. And for dentulous patient or teethy patient, we can use related ratio or red ratio or golden ratio. Later I'm talking about these items. For the edentulous patient, we should utilize the ratio between face and teeth. One of the common rules is 1/16. This ruler from dentsply, and for the height of the central incisor, 1/16 from hairline to the chin, and for the width we use 1/16 interzygomatic of width. For edentulous patient, if we want to design the smile, we use rule afters and 1/16 rule, or we can use true bite ruler from Dentsply company. But for dentulous patient, we need dental proportions, interdental proportions, or in other words, the relationship between widths of central, lateral, and canines and premolars in 5 view, not in cast view. This is the 5 view of the smile, and we know how to determine the relation of the widths in these teeth. As I mentioned before, for the proportional smile design technique, we should use 5 view. One of the proportional smile design or dental proportion is golden ratio. Golden ratio means that the width of the lateral to the central is about 62%, and the width of the canine to the width of the lateral is about 62%. Means that we have a constant or fixed ratio and constant or fixed number. But Preston in 1983 talked about only 17% of the patients can create for a golden proportion for them. And we can, what about 83% people? Lombardi at the denture time in 1960 used a related ratio. Related ratio talks about this distal tooth width to the mesial tooth width is a constant, but the number can be flexible, 62, 60, 66, 70, or 75, or 80%. In other words, the proportion of the width of the central incisor and the lateral incisors should be consistent between the width of the lateral incisor and the canine, and should move distally from the canine to the first premolar. Later, in 1990s, Dr. Ward talked about RED. RED means recurring aesthetic dental proportion. This idea comes from continuous proportion from Lombardi, and talks about the distally movement of this ratio to the premolar and second premolar and to the molar. If the elements of both concepts, Lombardi and Ward, Lombardi related ratio, Ward RED, are combined, one derives what the Ward has defined as the recurring aesthetic dental. The name is RED. Before, I mentioned you only 70% can be defined in golden proportion. Golden proportion like RED, but the difference is in RED the number is flexible and can be changed, but in golden proportion fixed to 62%. In this picture, you can see the definition of the RED. XY is constant, but the number can be changed, and in the golden ratio, the number is only 62, but in the RED or related ratio, the number can be changed and flexible. Because the dentist in RED or related ratio can be find out about the desired RED proportion. In this picture, the central width, the width of central is fixed and constant, but you can see the different RED ratio, 80%, 70%, and 62%. In figure A, 80% the canine is wide, and you can see more the canine width. In 70%, you can see the canine less than before, less than 80%. And 62%, you see the tiny canine in the file view. All of these dimensions and relations in 5 view. Dr. Ward, when he wants to desired rate, to define desired RED ratio, he notice face, skeletal structure, and general body type of the patient. Dr. Wards said for ectomorph, we should use smaller RED, and for the endomorph, we should use larger RED. Until now, we talked about edentulous patient, and the technique is ratio between face and the teeth. For dentulous patient, I talked about fixed ratio, and the difference between RED and golden ratio, the the number in golden ratio fixed to the 62%, but in related ratio from Lombardy and red from the Ward is a flexible number. But Dr. Ed McLaren and Coachman talks about flexible ratio and flexible number. In this picture, Dr. McLaren believes that the ratio between lateral widths to the central widths about 65% or 2 to 3. And the range between 60 to 70%. But for the canine to the lateral, 75 to 80%, and the range is about 70% to 90%. Okay, in this situation, or beliefs of McLaren and Coachman, you have a wider canine and tiny lateral. We determine the incisal edge by rule of thirds. Then we determine the width of the central and lateral and canine by some rules, different rules like golden proportion, related ratio from Lombardy, red from Dr. Ward, or Dr. Coachman and Dr. Ed McLaren talking about ratio and flexible number. But the only things that we can change now is the gingiva or margin of the gingiva, because the incisal edge was determined. Okay, then if we need the more longer teeth, we should do the surgery. For determination of the length of the tooth, we should pay attention to width to the height ratio. The dentist like taller tooth or longer tooth, and this ratio is about 78 or 75 to 80%. But the lazy people like to about 80 to 85%. The dentists like taller teeth than lazy people. Ward, McLaren, Dr. Cho from New York likes the 78%, and they have some articles about this ratio. In this picture, you can see the constant width or fixed width of central incisor, but we have a different red. And you see this, if we want to have a different red, we should change the height of the central incisors and other tips. And in other words, you see the relationship between red and different widths to height, or the height of the central incisors. Tall persons, tall face, or dolichocephal has a smaller width to height ratio, about 75 to 78. But the endomorph or short face, we have a larger width to the height ratio, or about 78 to 82 or more 85. We should notice the face and the shape of the face before designing the smile. In this article from Pascal Manier talks about the unworn dimensions of the tooth. He talks about 11 millimeters for central incisors, 11 to the 12 millimeters, but for lateral 9.5, and for the canine is about 10.5. In these pictures, you can see different widths to the height ratio from 71% to 80%. The length of the maximum length of the central is about 12 millimeter. The ideal ratio is about 75 to 80%, but 70 to 75 or 80 to 85 is acceptable. This slide from Dr. Ed McLaren. He talks about the width to the height ratio of central and lateral and canine in 5 view or facial view. Please notice all these ratios and dimensions from the 5 view. For central, ideal is about 11 millimeters, and the width to the height ratio is about 75 to 80%. For laterals, from 60 to 70%, and for the canine is about 50 to 55%. Please pay attention to this article. This is a nice article for the designing the smile. And this article is published in 2009. If we want to summarize the width to height ratio and the relationship between the red proportion is from Rosenthal, Ward, or Rashid. Some articles you can search in internet and find it. 75 to 78 width to the height ratio of maxillary central incisors preferred by dentists. Dentists like tall teeth. Normal length teeth about 70% red. If the dimensions of teeth is normal, the proper red ratio is about 70%. For very tall teeth, the red proportion is about 62%, and for very short and short teeth, the red proportion is about 80%. Before I want to talk about the softwares. In Nemotech software, we use flexible ratio and flexible number like Dr. Ed McLaren and Dr. Coachman. But in ExoCAD, we use red. Red, and like this slide, we should pay attention to the height of the tooth and the width to the height, and choose 80% or 70% or 62%. For every patient, if we want to design the smile, we should fill these form. And we should do facial analyses. We should do the rule of thirds for the face, for the whole of the face, and the lower the face, from subnasal to the mentone. We should check the M and E position and S video and F V video before treatment and after treatment. Dr. Ward summarized our designing technique for the smile is objective way. We should use the 5 and the red proportion, but Dr. McLaren and Dr. Coachman, they are our own techniques. Before I talked about that, and we should respect the nature and biology. We should respect the face and then design the smile. 7 steps for designing the smile. First step, incisal placement. Second step, rule of thirds for the face, whole of the face. Third step is rule of thirds for the inferior of the face. Fourth step is factors to determine to incisal edge placement, phonetic and occlusion tests. Fifth step, we draw the vertical midline. And the sixth step is dental proportion or inter-width proportion of the teeth. One technique for edentulous patient, face, the ratio between face and teeth. For dentulous patient, we use some techniques like golden proportions. Lombardi technique, the name is related ratio. The red proportion from Dr. Ward, or the technique, the method of Coachman and Dr. Ed McLaren. And the last step is intra-tooth proportion or width to the height of the central incisor. Until now, I have talked about 7 steps for designing the smile, but Dr. Coachman showed us his technique in 10 steps. If you have noticed this video, you see I explained all of these steps. Please pay attention to this short video from Dr. Coachman.
Why you always in the mood? Fuck around like it's brand new. I ain't tryna tell you what to do, but try to play cool. Baby, I ain't playing by your rules. Everything look better with a view. Why you always in the mood? Fuck around like it's brand new. I ain't tryna tell you what to do, but try to play cool. Baby, I ain't playing by your rules. Everything look better with a view. You know we get the task. When I saw me feel I was tired, so I was on the feeling bad. Baby, I ain't not so bad. It's not all you want.
Thank you for your attention. Any question, please contact by Instagram ID smiledesigner.me. In this video, I will show you the steps how to design the smile in Nemotech software. Please pay attention to this video. The time is about less than 15 minutes. First of all, we import the 2D video, 2D photo or picture. File view image. At least we need 5 view image or facial smile view. After that, we should draw the interpupillary line and align the photo in this software. We shoot this stage in precisely and draw the midline, vertical midline into the from philtrum, upper philtrum lip, and then import the STL or mesh from oral scanner or extraoral scanner. Then we should orient this model or mesh in this software. You can see it. Change the position and align to the midline. Determine the incisal edge. Now we should align this mesh to the photo. Mark some dots or points on the still and then on the photos, and then merge it or build this mapping. Then we should check the precise of this matching. Acceptable, and save these changes. I think this stage is like taking Facebook in analog dentistry or conventional dentistry. Now we want to design the smile. Before designing the smile, we should analyze this. First of all, we should determine the incisal edge and the midline of the vertical midline of this patient, and the width of the inter two canines in frontal view. And now determine the red or related ratio, or the technique from Dr. McLaren or Dr. Coachman, flexible ratio and flexible number. Now we should determine the width to the height of the central. The best number for dentist is about 78%, and in this patient we do not need any surgery for crown lengthening, and a little we should add to the incisal edge. And we see the 42.2 rule from Dr. Ed McLaren. All of this design is acceptable, and this analysis you see in her face and cast or steel file or mesh. Now draw the tip of the papilla determine the point of the papilla, and then we draw the line from the margin, gingival margin. You see this from central to canine, and we see the harmony between these lines: small line, papilla line, and gingival marginal line. And we see the ideal relations or red ratio. Now we should do the digital wax up for making traditional wax up or digital wax up. In this area you see the ideal relation. Save this situation. Now import from the library tooth anatomy for making shells or traditional wax up. Now we should set up these teeth. This teeth is set up by interrelation and intra width to height. You can see this setup is acceptable in all dimensions, width to the height and inter-width relation. You can check this setup in her photo and her face in 5 view. Now we should make a traditional wax up for real world or for our office. Select the teeth from canine to canine and then choose the base Now merged two meshes together and make a STL file for printing. This STL is now ready for printing, and then we can make an index and try in her mouth. Another technique is making shell. Again, select the teeth from canine to canine and then choose the base. Now generate the shell. Shell likes the veneers, real veneers. This shell can't be printed, and then try them. You see these shells. We can attach these shells by flowable composite for the temporary cementation and check the occlusion and aesthetics, and we can analyze all of these 7 steps and then start to treatment our treatment plan. Thank you for your attention. If you have any question, please contact me.
Thank you so much, Dr. Ismaili. I know that it bothers you a lot, but we hope we can have you again in our other programs, and it wouldn't be the last time that you come on a lecture with us. So
I am not stressful.
yeah, I know, I can understand. But you know that we always have internet connection, and it happens in live demonstrations everywhere, especially for here. So again, thank you so much. It was very informative and a very nice set of slides. I hope that our audiences have joined it as much as we have enjoyed it. So let's say goodbye to everyone and wrap the program up. I don't think we have any questions, and thank you for being with us, everybody. Thank you, our audiences. Thank you, the team that helps us to present this program. Special thanks to Dr. Ismaili. Goodbye, everybody. Goodbye.